For our records. Yeah. Okay. So, Dr. Indu Arneja is the founder director of the Indian Institute of Healthcare Communication that focuses on transforming healthcare delivery by conducting comprehensive knowledge and skill building programs for doctors, nurses, and management professionals. She has authored the book Fundamentals of Clinical Communication Skills, a step by step guide for medical students. She has had the honor to serve as a core group member of the advisory board on health and mental health for the National Human Rights Commission. She has had the opportunity to teach at institutions such as IIM Ahmedabad, XLRI Jamshedpur, NABH, National Human Rights Commission, Maulana Azad Medical College, Delhi, Delhi, AIMS Jammu, Orbis International, ECHO, the Delhi Judicial Academy, Delhi University, and the Public Health Foundation of India. She has conducted over 2,000 training programs, benefiting approximately 50,000 participants, mainly from the healthcare industry. She's a certified relationship centered communication facilitator. Dr. Indu has also initiated an online master trainer program to create a robust pool of trainers equipped with the necessary skills to impart healthcare communication, through which over 200 professionals have been trained. Additionally, she has also conducted 100 hands on training workshops in various colleges for undergraduate and postgraduate students focusing on clinical communication. We welcome you, ma'am, and we're grateful that you've taken your time out today. And now I yield the floor to you to begin your session. Thank you.
Thank you so much, Mrinalini, for such an elaborate introduction. Thank you, Ganda, for calling me, for inviting me for this program. This is something very, very close to my heart. I remember in 2019, I had attended the doctor-patient conflict resolution program at Bombay because I was very keen to understand how can we actually prevent these conflicts, and in case if they happen, how do we make sure that we can de-escalate at the right point of time. So friends, I have been into training for almost like 35 years. But for the last 10 years, I'm primarily working on our communication because I think that's one of the biggest challenge that we all are facing when it comes to the conflict that we get to see. And I'm sure you all must have noticed in your own practice. You all seem to be very senior professionals, so I'm sure you must have seen a lot of time when your resident or your nursing staff or one of your administrative staff or billing staff, if they don't behave well, if they don't listen to the patient party, or if they are not able to communicate effectively, it actually leads to a lot of unnecessary hassle. And then sometimes things go so much bad that they actually go out of hand, and we have seen litigation on the rise, violence on the rise. And these things are really very new to all of us. I don't think we saw anything of this sort maybe 10, 20 years ago, but I think this has become a very regular thing for all of us. And I'm very happy that CMC has taken the responsibility of creating a pool of people who understand mediation and who can actually take this forward. And I mean, I'm really very happy, and probably that's the reason why the moment Kanda said that I want you to be one of the speakers, I said more than happy, because I would be happy to talk to people who are like-minded. If you are here, I'm sure you have come here with the same ideology that we must address this as early as possible in the most suitable possible manner. So my session today would be covering primarily two aspects. So one would be importance and relevance of communication in healthcare. Although I know we all understand, but I would like to create deeper understanding for all of us, because somewhere we will also understand the root cause of the violence and the aggressive reaction that come for us. So how can we really understand patients requirement and also see how communication can actually bring a change in the whole situation that we are facing. And then second half will be on what essential skills can we really consider for any healthcare professional to know. So as I can see, most of you are very experienced, learned. Maybe what I'm going to talk will be something that you're already doing it. So my session will be more like, first of all, validating what we are doing already. So you will be happy that, okay, I'm doing this, so this is something which is really required. Plus, I'm sure this will also give you an idea about how do you go about training your staff members, your residents and your nurses and other healthcare professionals, so that they can be equipped with the same skills to prevent these kind of situations that that we are seeing day in day out. So it's going to be a completely interactive session. I'm going to ask you a lot of questions and I will request you to participate. If you have any questions, please raise your hand. Do ask your question. Let's discuss, because we are here to learn by discussing. So it's not a lecture session. Plus, there will be a lot of activities. I mean, learning by activities is one way that I have found to be more impactful than just didactics. So I will be doing a lot of activities. I'll ask you to participate on those activities, irrespective of your position, irrespective of your seniority. I would request you to participate so that we actually get to understand what we are talking about. So any question, anything that somebody wants to say or comment before I begin, before I go further? Are we all good to go? Okay, thank you, thank you. And whoever is there, if possible, please have your cameras on, because if you are visible to me, it kind of gives me an idea that okay, how many people are there, and then how do I really make sure that I'm able to engage you? Because every time going at the participant list and calling the name will not be possible for me. I request everybody to have your cameras on so that we can see each other and participate fully. Okay. So as I said, the first half of the session would be about importance and relevance of communication in healthcare. Now, if I may ask you, what do you think has changed in the last couple of decades that has really highlighted the importance of communication and interpersonal skills? Would you like to write on the chat box, or if somebody wants to unmute and speak, feel comfortable,
I
whatever.
think it's more of consumer awareness that has come up. There is so much of information that is all over, information which may be right, which may not be right, but it's available on social media, the videos, there is data available, and people tend to read that, have that half-baked knowledge and
Mhm.
feel that is authentic. And there are relatives and attendants of the patient also, they have a lot of information which they believe it to be true, and then they will instigate the patient or their relatives to uh, be violent, or that kind of thing. So the image of the medical profession, I think, has been affected due to a lot of such information. And then the moment something goes wrong, people want to really agitate and uh, be violent, or go for litigation or something of that kind.
Absolutely. I think you have really covered a lot of points. Would somebody like
Can
to
I
add?
add? Can I
Yes,
add?
Yes, ma'am.
I think
Sir,
one second, sir.
Madam, I would also
Rajan
like to ask.
Joshi has raised the hand. I'm sorry, I'm not able to locate. Okay, yes, sir.
Uh,
And then, sir, I come to you, Mr. Praveen. Yes, Mr. Rajan Joshi, go ahead, please.
Basically, I'm not a medical practitioner,
Mhm.
so I'm having it. I may be considered to be on the other side of this thing, patient side.
Wonderful.
Now, what my personal observation and my personal experience is that, as far as health is concerned,
Mhm.
people in general are not as conscious as they are expected to be. Basically, because our body and our mind keeps on telling us something
Mhm.
before some serious problem arises.
Mhm.
And most of the patients,
Mhm.
they are, because of the today's lifestyle or whatever easy access to the, sorry, access to the social media or internet. I
Mhm.
mean, it's they are trying to find out some sort of shortcuts.
Mhm.
As a consequence of which, when a person goes to the medical council,
Mhm.
basically he should be in a position to give a proper history to of his own and his family, or
Mhm.
his family members should help them.
Mhm.
And on the other side, what has happened is that because of the specialization is that is taking place in the medical fraternity.
Mhm.
Consequently, the doctors, many a times, basic thing has to be first looked at.
Mhm.
So if somebody has come for migraine to me,
Mhm.
now because I am a specialist, or I'm supposed to be MD and all this thing, so my thinking starts on a level basically
Mhm.
which doesn't go to the root of the problem basically. And this is what is in fact basically increasing the conflict between the patients and the doctors. That is what I feel. I
Thank
hope I am
thank you,
on
sir.
the right
Thank you.
track.
Thank you, Mr. Rajan, for pointing that. And it's good that we have medical professionals, and we have a mix of other, professions, so that we get both the perspectives. And actually, honestly, if we are going ahead for mediation program, then we have to be open to the idea of listening something that we are not really very, very happy sometimes listening, because when we listen to the patient's point of view, that may not match the way we look at the situation. So I think this is a good beginning where we have people from the non-medical background and they are sharing their thoughts. Thank you, Mr. Rajan, for sharing that. I think Mr. Praveen wanted to share something, and then Preeti ji, you can speak. Yeah, go ahead, Mr. Praveen.
See, overall, the education has gone up. See, earlier, people were from the village or not so educated or not so graduate.
Yeah.
They were not aware of their right. Nowadays, everybody is aware of their right. The social media has gone up. The overall reading has gone up. Plus, there is a total commercial world. Today, nothing, that respect one, I know as a childhood, whenever you used to go with the doctor, sir, vagare, sir, there was highly respect and as an attention. Now that is not there. Plus, whenever we go to the doctor nowadays, he tries to be very quick, within 5 minutes, the specialist tries to come and moves to the next patient. Not given the full attention that what is required. So
again, thank you. I think Mr. Praveen, you've also brought in a good point that people sometimes expect more time and interaction with the doctor, but because of the paucity of time, sometimes doctors are not able to meet that need, and sometimes some unsaid needs are not attended. That leads to dissatisfaction. I think that's a valid
doctors
point.
also
Thank
work
you.
very
Yeah, they are also
overburden,
it's
I think.
absolutely.
And
I'm
people
glad.
have realized they are right. The commercialization has
Yeah.
people have realized that, right? And that interpersonal relationship is not there now.
Yeah, thank
It
you.
is
I
totally
think
commercial.
the
Okay, this is my
realization
pure
that
thought.
if you're able to look at the situation from their point of view, probably we also get to realize they're also facing a lot of tough situation. So after Preeti, Kamakshi will speak. No, you don't. You want to say something? Kamakshi, no, you rose your hand. I thought you want to say something. So I think yes, Preeti, go ahead. Yeah.
Okay, ma'am, I'll just go very quickly. Good evening, by
Yeah,
the way.
very
Nice to see you here. Three things. One is there's been a lot of negative media against the doctors over the last few years, I've seen.
Yeah.
And I think that has increased the mistrust. That is the second part, because there's a lot of trust issues now between the doctor and the patient.
Yeah.
And the third thing that I have realized is that even if people are educated, they really don't know much about health. So even if a doctor is ready to explain to them for 20 minutes, they really can't understand much, because the basic nature of how much you know about your body or the systems don't work. So these three things put together, and what Mr. Praveen said, the commercialization, people think that we are all out to make money.
Absolutely.
So I think all that is there. I think that's it now.
Incidentally, all the money does not go to the doctor's pocket, it goes to the corporate sector. But then somehow they are the face of healthcare, so definitely it is assumed that the money is going to them. I really understand what you are trying to say. Thank you, Preeti ji. Yes, Dr. Deepa, go ahead, please.
Good evening. Actually, I think most points have been said, but I would like to tell one thing. Here, there people don't accept eventuality. Here, people think that everyone should live till eternity, and the only reason why a person dies is because the doctor killed the person. So that acceptance that was there years ago, that when the lady is delivering or when she is undergoing any operation at that point of time, it is very possible that the desired outcome may not be there. So initially it used to be only like ऐसे कैसे हो गया डॉक्टर आपने कोशिश बहुत की वगैरह वगैरह, but nowadays it's like तुमने गलत नस काट दिया इसलिए ये सब हुआ. That is what we are facing nowadays. It is a part
So
of the
there's a lot of
mistrust.
mistrust.
But
Dr.
there is no
Deepa, if I'm
acceptance
understanding you right, now there's a lot of mistrust and lack of
No,
confidence.
it's not mistrust. It's not mistrust. They want some assurance of the outcome. It's like playing a wager that they want a successful surgery or a successful everything, and that nobody should die.
So,
म्हणजे
Dr. Deepa,
even if
one
it's a
second.
old person who has everything.
I understand what you're trying to say, that they have unrealistic expectations. I completely agree.
Yes.
At the same time, my experience of working for so many years with the healthcare professional, it says that everybody expects a good outcome, especially if they're paying for the service. They come with the idea that I'm going to recover and I'm going to be fine, or my patient is going to be fine. So that means these unrealistic expectations are part of the cognitive process that the patient would have. That means as a healthcare professional, I need to be ready to even address them and help them understand that whatever you are expecting may happen, may not happen. I can assure you for the best of service and care, but I still cannot assure you for the outcome because that's not in my hand. So that communication still is needed, and that is what we are here for. And I think the whole, I'm sorry, Sonu, am I calling right, Sonuji? So, okay. Pardon me for mispronouncing your name, and please correct me if I mispronounce, because there are at times when you don't know what exactly you want to say. So we will be talking about all this, but one thing that I want to bring in here for all those who are attending mediation program. One, I have to learn to take a very neutral stand. Mediation requires a lot of neutrality. If I'm moving with this idea that I am right and the other person is wrong, then I'm sorry, I'm not at the right place. I'm sorry for saying this very straightforwardly, but that's what I see. Conferences that I attend, meetings that I attend, where we're talking about the violence against doctors, we just want to put all the blame on the society, on the system, on patients, and everybody else. I'm sure maybe a lot of mess is there on that side. But if I really want to correct the situation, I have to take the responsibility of correcting what I am doing wrong or what my people are doing wrong. If we move with this intention, I can tell you we can really create a lot of peace. Anytime if you try mediation and if the patient feels that you are not even neutral, I'm sorry, they will not have trust in you as a mediator. So I would really be very, very honest and brutal at this point. See, I'm sure some of you must have read that book by Stephen Covey, 7 Habits of Effective People. How many of you have read that book? Raise your hand, please. Not many. Okay, it's okay. I could see only Mrilani probably has read this. Am I right? So beautiful, concept Dr. Stephen Covey gives that, see, there can be 110 problems. Make a list of all those problems and then draw 2 circles. Actually, you can do it for you. If you have your copy and a pen in front of you, make 2 circles, one big one and one small one. All of you have a copy and a pen? If you want a minute to go and get it, I can wait, because that's the concept that's going to help you to actually deal with this situation. Okay, so draw.
Sorry.
Yes, Mr. Rajan.
No, the problem that the medical fraternity is facing is equally faced by.
Can I request you to hold on for a second? Why I'm saying this? Because I'm explaining a concept, and once the right time comes, you can please unmute and speak at that moment. Let me explain this concept so that I'm able to give you some solutions. See, I'm not here to lecture. I'm not here to preach. I'm here to give you some good solutions that will help us resolve the problem. See, we are all here for a purpose. This is not theory, it's practical learning. So I request you all to draw 2 circles, one big one and one small one. The bigger circle is COC, that is circle of concern. And the smaller circle is COI, that is circle of influence. Now pick up every problem related to healthcare, or even actually in your personal life. But since we are talking about healthcare, so we'll stick to that point. Pick up every problem that you see, in the healthcare that is bothering you. Check, can I do something about it? Do I have a control on it? Now, for example, if people are visiting Google, people are finding information on Google, can I control it? Can I stop it? Can I ask my patient, don't come to me if you read Google? I will not answer any of your question. We can't do that. So yes, this is a very genuine problem, but this cannot be directly influenced. So this will go to the circle of concern. My patient has unrealistic expectations. That's an important thing. Can I do something? Yes, I can talk to my patient and then explain that this is the probability, these are the complications, these are the comorbidities, this is the health status, or this is the situation. We are using standard treatment guidelines, but the outcome may not be as per expected. This is what we can do. If you want to go for second opinion, if you want me to talk to any one of your family member who understand medicine, I'm ready to explain, but this is the reality. That means I have a way to address that. So this will go in circle of influence. Pick up everything that bothers you, and one by one, either it will go to COC or COI. Very mindfully, please focus on COI. That is where you can actually pay attention and correct things. Put all your energy, time, efforts to COI. Yes, COC can be addressed. I'm not saying it cannot be addressed, but individually, probably in our capacity, we will not be able to address directly. So as mediators, as healthcare professionals, if I can sense that the patients are becoming aggressive, if I can sense patients are now more demanding, I need to find ways how can I deal with it. And this tool will really, really help you. It's a beautiful concept I use in my personal life, in professional life, and I recommend to everybody, when you start working on something, segregate. I think your list will be smaller, it will be easy to address. If you're focusing on everything, you will just be talking like we started the discussion and everybody's coming up with the problem, but who is talking about the solution? And if we don't talk of the solution, then it's just waste of time. We have to really focus on what can we do. And today's session will actually open your mind to the idea that in our own capacity, whatever we can do, we should do. We should set role models. We should do trainings. We should train our people. We should equip them with the right skills. And then you will see changing, things changing in your workplace. So let me quickly share the. Sonuji, do you have something to add to?
Yeah, no, just that for some odd reason, the common public thinks that doctors should not earn. So every time, they don't mind paying similar and higher fees for lawyers and engineers and other services. But whenever a doctor charges, it's like, itna sara I had to pay, and the consultation fees, and he's calling me again and I have to pay the consultant again. It's always that thing. I don't know why.
I
But they will
agree.
pay lawyers'
can
fees.
I-
They will pay
I
lawyers'
agree.
fees. They will pay chartered accountants' fees. They will pay all other fees.
I
But
agree
we
with what you
cannot
say.
charge.
Hold on. I agree with what you are saying, but at the same time, maybe the patient who comes and says, "Miki, do me free," I can tell that I'm sorry. I have a family to look after. I have these responsibilities to look into. So you can't. I mean, I can't be doing it free. But in general, I think addressing this opinion can be done through various platforms, but directly probably we will not be able to change this because that's how the society looks at the profession.
Yeah,
So
but that's sad. Yeah.
So
A
let me
doctor
share
cannot buy a high-ended car. A doctor cannot use a high-ended pen. I mean, it's
I,
literally like that,
so I can see a lot of resentment. I understand, and I'm not disagreeing, and I'm not saying that why is this, because I know this is very true. But at the same time, see, we have to become more open to the idea of exploring what are the ways to deal with that situation, rather than just cribbing over it or being upset about it. Let's work on what can we do in our capacity to change the situation. So as I said earlier also, I mean, things were much easier. Medicine was very simple, easy, respected. People literally, respected doctors as, God. But we all know that these things are changing at a very, very fast pace. These are a couple of things that I have noted down. Most of it you have already covered. Like they have become more aware, they have access to information. Since they are paying for the service, their demands and expectations have gone up. As a result, our answerability has gone up. And we see that aggression and stress is very high in general in society. And it's not just for the patient. I think even we as professionals also are aggressive and stressed out most of the time. As a result, there is increase in the patient-hospital conflict. We all know that we are not able to handle media because the way they exploit the situation and the way they portray it becomes sometimes very difficult to justify your stand, and you can't go and explain what exactly happened and what the truth is. somehow we have not been able to, develop professional even relationship with them, which is an area that we have to really, consider how we can make that happen. As a result, I think litigation is on the rise, although we never heard of it maybe 20, 30 years ago, but now I think very regularly we are getting to hear about this. And also the extent of fights have changed. It used to be usually verbal, or at the most somebody will become aggressive and talk ill about you. But today we know people don't hesitate, hitting healthcare providers and doing all sorts of violence, or even damaging the hospital property. So all these changes, I think, bring us to a point where we need to really work on our way of handling patients and their family members. I think one of the area that we need to focus on is patient communication. Now let's see, what do studies say? There's a study, that's by Institute of Medicine. It's a very reputed organization, and that says that our communication with the patient is often inadequate. One of the reasons is that most of us lack adequate communication skill training. Only recently, 2019 onwards, they have introduced a module called EdCom module. I hope some of you know about that module. No. So 2019, National Medical Council revised the curriculum for the medical students, and they have introduced EdCom module, that is attitude, ethics, and communication. So they are trying to talk about it right from the year one, so that the doctors or medical students actually become familiar with the idea of effective communication and ethics, and having the right attitude towards patient and society on the whole. For the last 10 years, I am working with Maulana Dad Medical College with the final year students, where I'm trying to work on their communication skills and interpersonal skills with patients and their family members. So it's a full 1-day program that I do with the students of say 30, 35 in a batch. So around 8 to 10 programs are done. Although this can never fulfill the complete requirement, but at least there's a beginning made, and then there is some realization that these skills are essential and required. But very honestly, we are still far away from the actual real training happening in medical colleges, where students take it seriously, where teachers impart it seriously, and where these skills are assessed at the examination level. Only then probably these will be taken seriously, but actually studies suggest that our communication is not really being attended. This is another study where orthopedic surgeons were surveyed for their communication satisfaction. 75% of the orthopedic surgeons said that they are satisfied with their communication with their patient, whereas when their patients were asked, only 21% of the patients actually admitted that yes, they were happy with their doctor's communication. So you can very well see the gap. What we think that we communicate may not be taken as well by the patient. So as a result, automatically the huge gap that is between their expectation and what we are doing probably is one of the reasons why we are experiencing a lot of violence and aggressive reaction coming from the patient party. Studies also suggest that our communication does not meet the basic standards of informed decision making. I know a couple of decades ago, decision making was completely a doctor's prerogative. So we decided on the patient's behalf that this is what you need to, get done, get surgery done, get admitted, start this medicine, stop that medicine. And that was really, working very well. But it is realized that that's not actually really working for the patient. A lot of time, what we think is in the best interest of the patient, it may not suit our patient. So therefore came the concept of practicing shared decision making, where we actually negotiate with the patient, help them see what are the options available, and then what would suit them best. But then since we are used to that kind of practice, it's very difficult to actually let go of that prerogative. So we still are not very comfortable with the idea of shared decision making or informed decision making. I think you would be knowing from your own experience, a lot of doctors, I mean, a couple of decades ago, I remember the consent used to be taken by nurses. It's a recent development that now we are asking doctors to explain and then get the signature, but we all know how much of explanation is really done. So as a result, the patients are not given complete information, or they are not happy with the way they are explained, or even when we explain, the jargon that we use probably sometimes don't make sense to them. They would be just nodding, yes, I understand, but a lot of times they don't understand much. And then later on they say that I wasn't explained, or I did not understand well. So this is a recent survey in India. Those studies were not from India, so I'm sure you must be wondering that this is not India. But this is a recent survey done in India by ICC, CRMAA, and Taragini. It says that 45% of the families reported that they did not have adequate clarity on the diagnosis. They also said they did not understand the treatment and the care options available to them. At the same time, they perceived lack of involvement in deciding the treatment, and they reported it to be more like a rushed consultation, and they felt unempowered in the treatment of their patient. So I think this gives us a fair idea that 50%, almost 50% of patients are not very happy with the way we explain them about their diagnosis or treatment or care options, or actually engaging them. But they still come to us, they get the treatment done. But the whole idea of empowering the patient and the family in their treatment is miles away from the reality. Almost 1/3 of the patients indicated that they were not allowed to describe their condition or symptoms. Any idea in how much time do we interrupt the patient? Average, I'm not talking about 1%, average. In how much time do we interrupt the patient when they start narrating their problem?
15 seconds.
Very close, sir. The latest is 12 seconds. Very close. So you can well imagine nobody can actually talk about their problems, in 15 seconds. So they feel somewhere that their problem, they have not been able to talk about their problem. Maybe because a lot of time when we look at them, we are able to make a diagnosis. So if a patient comes with, with conjunctivitis, it would be just a second's job for anybody to see that it's conjunctivitis and this is the treatment that patient requires. But when patients are able to talk about their problem, the pain and the suffering also gets reduced if they are able to talk about their problem. But almost 1/3 of the patients said that they could not describe their condition or symptoms in detail, and that actually led to dissatisfaction. Almost the same numbers say that their doctor did not straight away address their questions and doubts. Again, probably since we are not in habit of having patients who ask a lot of questions. I'm sure many of us get upset when the patient asks more than 1, 2, or 3 questions, and we have a mental note of it, or this patient is very demanding, or this patient asks a lot of questions. So we kind of we are not very happy interacting with those patients. But at the same time, today patients want to ask a lot of questions about outcome, prognosis, complications, relapse, second opinion, cost. So these questions, when they are not addressed, they are again unhappy with us. And as a result, I think almost 1/3 of the patients have reported that they were not satisfied with the way they communicate, their doctor communicated with them. So if I may ask you to write in the chat box, what do you think are the benefits of learning communication? How are we going to be benefited if we learned how to communicate effectively? And I request you to write in the chat box. I hope it is convenient for everybody to write in the chat box. You could just write the key point, even that's okay. How do you think we are going to be benefited? Okay, will make my job easier, absolutely. It will reduce stress, no doubt. Okay, both parties can be on the same page. Wow, that's a wonderful thought. Reduce misunderstanding. Yes, I agree. Listening is the key of communication. Absolutely, absolutely. And understand why the person feels that way or has a certain opinion. Yes, you get more clarity on what they are thinking and why they are thinking. It will help us to understand the patient. Absolutely. So if we communicate it effectively, I think a lot of benefit can actually happen. Patient will be happy and you will be happy and you will be on the same page. Also, at the same time, let me tell you, if you communicate it effectively, actually the medical errors would go down. Lot of medical errors happen because of communication failure. You'll be surprised to know that according to a report by JCI, medical errors are the third commonest cause of death in US. We haven't done any study in India. I don't know if we did, where we will stand. Honestly, healthcare industry is considered more dangerous than aviation industry and nuclear industry. This is another study by Professor Ashish Jha from Harvard University. He estimated 5.2 million medical errors happen annually in India. So errors like wrong site surgery, wrong medication, wrong organ removal, wrong treatment, wrong patient are very common. Only 3% of the errors get reported. 97% of the errors are brushed under the carpet. As a result, we don't get to know what errors are happening right under our nose. Most of these errors are around medication error, patient care, and surgical error. So if we became more, communicative in these areas, I think we'll be able to prevent these errors. 60 to 70% of the errors are result of poor communication. Let's do a small activity. I would be sending 5 of you out in the waiting area, and we'll get you all one by one. I'll be choosing doctors because I want, because they will be familiar with the information, so it will be easy for them to interact. I hope that's okay with everyone. Okay, so I'm not choosing anyone, but whoever name comes first in the list, I will be, putting you in the waiting area. So I can see Dr. Sudhir Rai. Sir, I'm going to put you in the waiting area and I'll be calling you back. Thank you. And then I have Dr. Deepa. So, ma'am, I'm sending you to the waiting area and I'll get you back. Then I have Dr. Subodh. Again, I'm sending you to the waiting area, 3. And then we have, I can't see anybody's name with the doctor. Prishali, are you doctor? Okay, Preetiji, you are doctor. Okay. Preetiji, have we met earlier?
Not
Okay.
sure, ma'am.
Okay, thank you. So I'm putting you in the waiting area.
Sure.
Okay. So I need one more person. I think Sonuji, you are also doctor? Okay. So I'm sending you to the waiting area. So I hope I have one doctor in the one second. Have I put somebody else? Okay. So anybody who is doctor here? None of you? Vrishali, Kamakshi, nobody. So
Sorry.
yeah.
I think there is one doctor in the room. I think Dr. Ketki Bhatt. I think she doesn't have a doctor written. She's also doctor.
But I can't see her in the main
No, she
area.
has a video off actually.
Oh, can I
She
request
said
her to have her video on? Okay, in that case, no problem. I'll take one of them because I need to do the activity. So I think I will bring in Sonuji. Huh? I'm admitting her. Okay, no problem. Okay. So Sonuji, I've taken you back because there's no more doctor in the main area, so I've taken you back. So I'm going to show you a slide, and I want you to read that content to yourself. All others will also be able to see the content and read it, but you have to read it to yourself. All of you will be observing the whole activity being done. I request you not to speak in between, just observe the whole activity. So let me share the screen and show you the slide that I want you to read it to yourself. Are you able to see? Is my screen visible to all?
yes, ma'am.
Okay, yes. So Sonuji, just let me know when you are done. Are you ready? Please unmute your device. I'm not able to hear you.
Yes.
Okay, thank you. So I'm going to get one person from the waiting area, and whatever
Hmm.
you understood, I request you to share that with the person who comes in. So let me give the instruction to the next person, and then you can start speaking. I've taken in Dr. Deepa.
Hmm. I have to tell her.
Yeah, wait, let me first tell her because she may not know what is her. Yeah, Dr. Deepa,
Yes, ma'am.
can I request you to have your camera on?
Madam, I've got the problem at my end with the internet. I'm on the mobile phone. It is coming
Okay.
and going all the while. I'm really sorry about this.
Okay.
I'm extremely sorry. I'll try. I'll just. I mean, I'll figure that out how to stabilize it. But just a minute. I mean, my cabin doesn't have too good a
So
video.
what I will do, I will send you back to the waiting area and I'll take somebody else. Once you are ready, then I will take you in. Is that okay? Meanwhile, you can
Fine.
stabilize. Yeah, meanwhile, you can
Yeah,
stabilize.
yeah. I'll do that. I'll do that. I'll do that. I'll do that.
Sure. Okay. So, Sonuji, I'm getting Dr. Subodh.
Yeah.
Okay. So let me explain to him and then you can start speaking. Yeah. Dr. Subodh, can I request you? Oh, thank you. So, Subodh sir, Dr. Sonu has a set of information. So she is going to share with you. Please listen to her carefully. Dr. Sonu, please go ahead.
Yeah. 21-year-old male patient, Mr. Neeraj, on ICU bed number 1, was operated today for a calcified tumor on the third and fourth rib. He was operated by cardiothoracic surgeon Dr. Shetty. Now, post-operatively, he is complaining of numbness below the nipple. Now, Dr. Shetty has left for the day, and he was contacted telephonically and has requested to send for a neurology reference. So we have to send the reference immediately.
So, Dr. Subodh, is that okay? Have you understood? Okay. So I'm going to get one more person from the waiting area. And now, Dr. Subodh, I will request you to explain whatever you have understood to the next person. So I'm taking in Dr. Sudhir. So I request you to, explain to him whatever you have understood. But let me first explain what is the whole activity about. Okay. Dr. Sudhir, yeah. Dr. Subodh has a set of information he's going to share with you. Kindly listen to him carefully. Yes, Dr. Subodh, please go ahead.
Hi, Dr. Sudhir. I have to pass on this information to you that Dr. Shetty, who is the cardiovascular surgeon, he's operated on a 21-year-old Mr. Neeraj because he has a cyst on the third and the fourth, in the area near the third and the fourth rib. And he's been operated already. And later on, he develops numbness in an adjoining area. And Dr. Shetty has already left the hospital premises. So we need to get a reference done for the neurologist to identify the cause of this particular numbness. So I would request you to send a reference to the neurologist.
Okay.
Okay. Dr. Sudhir, is that okay? Have you understood?
Yes.
Okay. So I'm going to admit one more person from the waiting area. And I want you to explain that to Dr. Preeti. So I think Dr. Deepa is not here. Mrinalini, can you check?
Yes, ma'am. I'll
I think
check
she has
with her.
some challenge with her internet, I believe. But meanwhile, I think we can at least, take in Preeti and then Dr. Sudhir can explain. So, Dr. Preeti, Dr. Sudhir has a set of information he is going to share with you. Kindly listen to him carefully. Go
Yes,
ahead,
ma'am.
please. Yes, sir. Go
Good
ahead.
evening, Dr. Preeti.
Yes, ma'am.
Dr. Subodh has passed on a message which
Mhm.
needs to be passed on to you.
Mhm.
Dr. Shetty, who was a CVPS surgeon, has operated on a 21 years old boy, Neeraj. He had a cyst in his chest along second and fourth rib, which was operated, and following that, he has some numbness, for which a reference to a neurophysician has to be given. Dr. Shetty is out of station, so you are supposed to forward this reference to the neurophysician.
So, Dr. Preeti, is that okay? Have you understood?
Yes, I've understood the issue.
Okay,
Yeah.
hold on. So, Mrinalini, is Dr. Deepa around or no? Not yet.
Sorry, ma'am. I just tried calling her. I think she might be joining in soon. So
That's okay. That's okay.
Yeah.
I think we will not wait any further. Okay, Dr. Preeti, whatever information you have received,
Mhm.
can you please repeat it to everyone?
Yeah. So, Dr. Sudhir said that Dr. Shetty has operated, he's a CVTS surgeon, and he has operated on a 23-year-old who had a cyst between the second and the fourth rib. And the patient, after surgery, has developed some numbness. And Dr. Shetty is not in town and has asked me to refer the patient to a neurophysician to take care of the numbness.
Okay.
Yeah.
So I have Dr. Deepa. I think Dr. Deepa is here. So have you admitted her? Mrinalini, have you admitted her?
yes, ma'am. She's here.
Dr. Deepa, can you have your camera on?
Yes, ma'am. Just in a minute. One second.
Sure.
But I just missed the name of the patient. Should I add that or let it be?
That's okay. That's
Yeah,
all right.
okay,
Yeah. So
fine,
whatever
fine.
you have understood, please explain to Dr. Deepa.
Yeah.
So Dr. Deepa, Dr. Preeti has a set of information she's going to share with you. Please listen to her carefully.
Yeah.
Yes,
Deep-
ma'am.
Deepa, can you hear me now?
Yeah.
Yeah. So Deepa, there is Dr. Shetty, who's a CVTS surgeon, and he's operated on a 23-year-old boy called Neeraj. And he's had a cyst in between the second and the fourth ribs. And post-surgery, he's developed numbness. So Dr. Shetty is not in town and he has to be referred to a neurophysician, and you've been requested to refer him to the particular physician.
Okay. So, I'm doing the locum for Dr. Shetty.
Okay. So Dr. Deepa, can you explain whatever you have understood in your words?
Yeah. See, basically what has happened, before I speak to the patient, what I have understood is that the patient was operated upon, and there was one of the complications which happened to this patient, and that complication could be a result of the procedure itself, could be a resolving thing. There were a lot of ways. It could stay, it could go away. There are a lot of possibilities, but it could be related to the surgery, maybe a part of the surgery, may not be a part of the surgery. So this patient needs to be told that he has, the relative will have to be told that the young boy has got this kind of numbness. It is not the commonest thing to happen, but it can happen because the nerves and everything go around the part which was being operated. The vessels and the nerves travel together. And because there was a cystic swelling, and because the patient has undergone a surgery with the vascular surgeon, it was some kind of vascular thing very close to the nerve. So the doctor has taken that out. But what can happen is that whenever we take out a tissue, it is possible that there is a swelling in the tissues, and that swelling can compress the nerve. And the compression of that nerve can sometimes cause that nerve to become numb.
What is your role, Dr. Deepa? What is your role here?
My role here will be talking to the patient on behalf of Dr. Shetty. So I will have to
you lost network.
first know what Dr. Shetty has actually explained.
Okay.
Even if I don't know what he has explained to the patient, what I can tell the patient is that you have undergone this surgery. These
Hold
are
on,
the
hold
known
on.
effects and side effects.
Hold on. Thank you so much. So friends, what happened? What happened?
The message got diluted or changed.
Chinese
or...
whisper.
Through this activity, I think this is what I wanted to, bring to everybody's, awareness, that we all think we communicate very effectively. And I deliberately included only doctors because it was little complex information. I didn't want any non-medical person to be involved. Otherwise, we could have said that because that person does not know, that's where probably he messed up. But the reality is we all think we communicate well, and the proof is right in front of us. Friends, I shared a real life case with all of you. And you know what happened in this case? Let me show you the outcome. So first of all, I think I show this slide to everyone like who was out in the waiting area for you to read what was the actual information. And you know what happened actually in this case? The seriousness of the situation got lost. The information got corrupted. Neurologist came to see the patient after 16 hours on the next day, after the first complaint of numbness by the patient. Patient suffered irreversible paraplegia. And then, of course, he had to be compensated by the hospital. Most of the errors in patient care are outcome of communication failure. And those of you who were thinking that these people did not communicate effectively, any one of us had been in their place would have made the same error, because we think we are communicated, but we are actually not communicating. A lot of time, we are not even coordinating well with each other. Patients with comorbidities like diabetes, hypertension, and something else, either they receive double the dose or they receive no medicine. And we have seen this happening. So most of these errors are because we don't coordinate well with each other. If we communicated effectively between us, I think a lot of good can happen. Patient will be taken care of. Their safety will be looked after. There'll be continuity of care. So sensitive communication like breaking of bad news, end of life care, grief, counseling are some of the intense communication. And because if we have not learned how to do it, I'm sure all of you must be really good at it because by now you have already learned by doing. But what about the staff members or the residents who are actually facing the situation, who are handling the situation, but if they're not given enough training, how do you think they will be actually doing justice to this role? As a result, studies have shown that almost 70 to 80% of the patients and family members have reported this to be a suboptimal experience. Unless you really know how to do this, how to handle emotions, how to counsel them, how to explain them, how to answer their questions, how to explain them the poor prognosis, or unless we really learn it, it's very difficult to actually do such communications without any training. Some of you who must be good at it, maybe you are able to pull through. But talk of those who do not have good vocabulary, do not have good language skills, do not know how to handle emotions. They are the one who actually face the brunt of the situation, and they are the one who would mostly experience aggressive reactions coming from the patient party. Effective communication can actually reduce the risk of allegation of medical negligence. Like some of you said, that they easily blame us for the outcome. That's how the human mind processes. If I keep a glass on the edge of the table, if somebody has kept the glass in the, on the edge of the table, and if this glass breaks by you or by me, what do you think will be the first statement that will come out from our mouth?
Why did you keep it there?
Why did you keep it there? Who kept there? Who kept this glass here? So we want to blame others. And somehow, healthcare professionals become the easy target, especially if we have not explained them the prognosis, if we have not prepared them for the eventuality, if we have not told them the risk involved or the possible complication. They assume that because I'm getting treated and I'm in one of the best hospitals, so definitely the outcome is going to be great. Over and above that, if our communication with them is not adequate, they are likely to experience anger, aggression, unhappiness, and the choice that they take is to litigate the hospital or the doctor. In almost 2/3 of the cases, you will see that patients, have sued the hospitals and doctors not for poor communication or not for medical negligence, but for poor communication. And this is Number of studies that have shown, even a recent study by IMA has also shown the same evidence. If we communicated effectively, I think we can handle conflicts effectively. How many of us really know how to de-escalate an aggressive patient party? How to handle uncooperative patient? How to handle unrealistic expectation? How to, prognosticate? So these are the things, and maybe all of you are very senior and you must be doing it. I'm not doubting your, capability, but I'm talking about the masses, and I'm talking about the, RMOs and the resident doctors who are still, learning the ways of life. I'm talking about those doctors, and I'm sure you would understand that unless they really learn how to handle this situation, they will be really in a state of violence. And that's the reason why they experience more violence than anybody else, because if they are not able to communicate effectively, they're usually taken as being negligent or being insensitive. If we communicated well, I think one of the best outcome after everything will be that we'll be happy about what we are doing. Now, if I may ask you, if we communicated effectively, how will the patients be benefited? Write in the chat box. If we communicated effectively, how will the patient be benefited? Write in the chat box. Okay, feel understood. Their expectations would be more realistic. Absolutely. Better outcomes. Yes, Dr. Deepa, you're spot on. Absolutely. And then, of course, better outcome. Dr. Sudhir has also written the same thing. Better outcome. Absolutely. Satisfied even if he does not get well. Absolutely. I think, Mr. Rajan, if somebody explains that this is what it is, I think the person would know. I mean, I can go to 10 doctors, and if everybody says the same thing, that means this is what the reality is. They will participate in decision making, and onus will be on them too. Absolutely. I think this is one important benefit of practicing shared decision making. When you explain them everything and when you make them take a call, they will ultimately come up to you and say, sir, aap bataiye kya karna hai? Ma'am, aap bataiye kya karna hai? Because you know what is in my best interest. So, but then they will be happy that they were involved and they were engaged. Absolutely. So I can see a lot of answers in there. Yeah, more transparency will lead increased trust. Yes, Dr. Sonu, I can't agree more. I completely understand what you're saying. And they'll prepare themselves to accept the outcome. Again, Ketki, I think you're very right when you're saying this. So that means ultimately, if we are able to engage them in communication, they will know what is the prognosis. They will accept it better. And like Dr. Deepa said, that there will be some of you said that there will be a different outcome, because studies have shown that patients who had who experienced effective communication coming from their provider, their outcome changes. They have a better pain control. They respond better to pain management modalities. Even chronic conditions like diabetes, cholesterol, hypertension, HIV, glaucoma, even these patients, they have shown better outcome just because they have effective communication coming from their healthcare provider. Simple example, when you say you need to make lifestyle changes, need to make dietary changes. When you say like this, they may not understand much. But if you spend 5 minutes and explain them what exactly you mean by lifestyle changes, that you need to go for a walk, maybe 20 minutes in the morning and 20 minutes in the evening, or if you are a diabetic patient, instead of taking 3 meals, divide that same quantity of meal in 5 meals and take small bites. That would help control your sugar, and these are the foods you are not supposed to be taking. They are direct sugar. So when you explain them these things, when I say you explain, it's either you or you're one of your team member. It could be your patient counselor, it could be your nurse, it could be your RMO, whoever does it. But if somebody communicates these things, automatically they will comply with what you are saying, and their outcome will be improved. Studies have also shown that even in cardiac surgeries, after cardiac surgeries, there has been a decrease in the post-operative complications such as cardiac arrhythmias when we communicate effectively. When you communicate effectively, they comply better with your advice. they listen to you, they follow up, they take medicines, they bring in changes that you advise them to take, automatically that would improve the outcome. Also, at the same time, they'll be very happy with you. Patients actually do not care for your degrees, they care for your communication skills and in your interpersonal skills. You know, a study by Harvard that says 85% of your professional and personal success comes from your communication and interpersonal skills. So you may have seen some of your friends who are average doctors, but those who have excellent communication skills and interpersonal skills, they are far more, they have a huge practice and their patients are far more satisfied with them. Now, what are the benefits of learning communication to the organizations? So if everybody communicated well, how do you think organizations will be benefited? So again, I request all of you to write in the chat box. I can see some answers. Okay. Lesser medical legal cases. The reputation of the healthcare facility will definitely be good. Good caregiver and with least grievances. Increased goodwill and patient would recommend. Absolutely. Relation would be great. Reputation benefit. Build a brand image. Absolutely. And then team efforts and better result. Absolutely. I think you have covered almost all the points. Any idea what percentage of your patients come through the word of mouth that your patients spread about you? Sorry? Dr. Subodh, it is 75% of your patients. That's the beauty of sending a one patient satisfied. They become your brand ambassadors. They would send you a chain of patients if you sent your patients, satisfied.
Yeah, I non-medical have written 80%.
Yeah, 75 to 80%. Studies show that 75% of your footfall is because of the patients referred to you by some of your satisfied patients. And how many patients read your Google reviews when they come to you? Dr. Deepa, you're saying none. Dr. Subodh says no idea. Yes, we are not really tech savvy, so we don't care much. But honestly, in a metropolitan city, almost 50% of your patients will look for your reviews before they come to you. They may not come and tell you, sir, I have seen your reviews. But almost 50% of, especially youngsters, I'm talking about millennials, especially youngsters, before they even buy anything on Amazon, first they will see reviews. I think I have some young, millennials with us, so they can tell us that, especially if they are visiting a doctor, they will always read your reviews. That's the importance of making sure that as an organization, also you have a clear image where you are seen as a good organization. So if you have good communication in the as a culture with the patient, with their family members, among us, definitely it will create good work environment. The energy there will be very different. You will see enhanced safety and quality, not just for the patient, but for the staff as well. There will be a greater job satisfaction. Attrition will be low if there is greater job satisfaction. Patient experience scores will be high. Patient loyalty will be improved because they will not only come, but they will also recommend to others. And also, overall, your brand image will be improved or better. So in nutshell, let me remind all of us that communication in healthcare is not about niceties, not just about niceties. We think communication is about good behavior. That's one part, but it is the therapeutic communication that happens between you and your patients. It is the clinical communication between you and your team members. It is part and parcel of the treatment, and it is not optional. it has direct impact on the continuity of care, patient safety, and treatment outcome. There are set communication protocols for every communication situation. We all must learn, practice, and demonstrate. There are multiple ways to learn and implement these skills. I think this program itself will empower you with a lot of understanding about how effective communication plays a big role in preventing conflict and aggressive reaction coming from patient party. Before I go further, any questions about whatever we have covered till now? That's the end of part 1, but I want to give 5 minutes to all of you if you have any questions to ask. No questions? Okay. Any comment? Any feedback?
What I feel is that apart from the communication part of it, but many a times more dependence on the labs. Is it not also affecting, because if an improper report is generated by a lab, honestly speaking, I was about to be a victim of an inappropriate report, because in 2018 I had a puerility, and about 850 milliliters of water was taken out of my right side chest. And the most of the reports were actually negative as far as TB is concerned, and only one report said that it is suspected TB. And to my horror, or rather I was saved because of my own sixth sense perhaps, that the doctor had prescribed me that entire TB treatment. And it was I consulted after a few months to some other doctor, and he also asked me, have you not yet started your TB treatment? And then I don't know why my sixth sense again worked, and I told him that this poor weather condition is affecting everybody. This coughing and this thing is going on, because I found that doctor himself was coughing in my presence. And then I just brought one air purifier, and I continued with my homeopathy treatment. Of course, I follow the homeopathy rather than allopathy. And surprisingly, without having any medicines related to TB, I am healthy, and I have taken trips abroad also without having any problems. So sometimes
diagnostic error, since we are not talking about diagnostic errors, I mean, if we had that part to be covered in the program, then
frankly
definitely.
speaking, this was second or third time when I was suspected by the doctor that I am suffering. Allopathic doctors diagnosed that I may be suffering from this thing. But twice at least I have, without having
A
any
lot of times symptoms, for 2 or 3 diagnoses could be very similar. So, I mean, there can be, a confusion about the clear diagnosis. And you're right, diagnostic errors do happen. I'm not denying that fact. But since we are focusing on the communication part, so of course, a lot of diagnostic errors are because if we don't allow the patient to speak, and if we don't ask right questions, we don't get complete information. I'll be talking about it when we talk about the essential skills. So that is one of the questioning skill I'm going to talk about. Thank you for bringing that up. Any other comment or question if somebody wants to make before we move further?
Just a comment, ma'am.
Sure. Go ahead.
I think you're starting at the right time when you're, I think, talking to the newly joining MBBS students. I think from there it has to start, because I think that generation, the moment it learns correctly, I think by the time they actually graduate and come out, that essential skill was really missing. So I think that's really good. Thank you.
I completely agree with you, and I'm very happy that now this is being addressed at the curriculum level. So we hope some change would at least be visible. But of course, they need to have a lot of role models who actually are doing things right. Plus, at the same time, I think if what they learn and if they're not able to actually implement when it comes to the real situation, because of any reason, it could be workload, it could be the lack of infrastructure, lack of the low workforce. So those things actually do not allow to implement whatever they have learned. But I hope slowly things will definitely change. Thank you. Yes, Dr. Sudhir, you wish to say something. Please go ahead.
Yeah, sometimes what I have seen is that when we start with a negative response, the communication closes. Even if you are a good communicator, they tend not to listen to you. This is one of the factor that changes their acceptance.
Absolutely. Definitely. And these skills we are going to talk about, whatever you're pointing, that's so very interesting and useful. And we are going to cover in the second half of this particular session. So let me quickly take you to through two videos. Fortunately, these videos have been done by Indian doctors. So you will be able to relate with them and you will be able to see exactly how we now do. The first one is how usually we communicate. And second one is what is a better way of doing it. So when you are watching videos, I would request you to write down, in the chat box, but don't click the enter button, because if you click the enter button, chat box will be flooded with the messages. But just keep writing what you are observing, and then when the video is over, then you can press the enter button, and though we'll be able to see your message. So let me show you the videos. I primarily want you to focus on overall body language, eye contact, attitude, and of course the language that the person uses. And that should at least make us aware of some of the things that we do unknowingly, but how that can impact the doctor patient relationship. So let me show you the video. 1 second.
Next. What? Doctor, my leg is swollen and painful. Since when? For the last 5-6 days. What were you doing? Why did you wait so long? This looks pretty bad. Doctor, I thought the pain was just a strain in the leg. Anyway, what do you think now? You could have waited for some more time and we could have amputated your leg. Leave it. What's your sugar level? It is under control, doctor. The fasting was 140. When was it done? What was your HbA1c? It was 4-5 months ago. Actually, HbA1c is an expensive test and I was feeling all right. So, I can't understand. You do investigation according to your will. You don't take proper treatment. You don't follow our advice. I don't know why you need doctors. And you come up with all sorts of complications like this. And what did you do with your leg? I went on a pilgrimage to Sabrimala, so had to walk barefoot. I might have injured, I think. Barefoot? Hello? Yeah. Who? The patient Ram, HIV positive patient. So he doesn't want CT scan. So tell him if he wants treatment, he needs to undergo CT scan. Right, what does he think of himself, yeah? Prime Minister or President? See, discharge him against medical advice and tell him not to come to this hospital once again. Okay? Yeah, bye. And you got this boon. I'll tell you, if you go once again, you will also go near the God. Didn't I tell you about the foot care when you came last time? Huh? And your smoking is continuing without interruption, I guess. I have reduced a lot, doctor. I am smoking only 1 or 2 cigarettes a day now. I can't understand your attitude here. You do smoking, you are overweight, you don't take medications, you don't do investigations. I don't know what to tell you. I'm trying, doctor. And if you don't want to see me, I could consult someone else. See, whatever I'm telling is for your good. I don't know how to tell. I gave you information leaflets last time and you're not following my advice. And if you don't want to see me, it's fine with me. I have got enough work to do. I've got enough patients to see. Sister, please call the next patient.
Okay. So what has been the observation? I can see a lot of comments coming in the chat box. Okay, where we are? Okay. Body language, attitude, eye contact, languages. Okay, Mrani has shared the key points, what to observe. Okay. Not interested in making eye contact. Absolutely. No eye contact, very rude. No eye contact, not focus, which is confidentiality about the HIV. Absolutely. I think that's one thing, when he talked about the patient by calling his name. No empathy rather than scaring the patient. Yes, using threat to scare the patient or to comply the patient. The patient has come with the complaint, but the doctor seems to be complaining. Body language indicates least interest in the patient problem. No eye contact, initial time reduced, confidence level with the patient. The language was very rude and lacks absolute empathy. Attitude is very careless and inhumane, not concentrated with the patient. Took some other call, blaming the patient, high-handed, no, not sensitive, curt, rude, poor eye contact, uninterested, in insulting, bad attitude, rude, distracted. Almost everything like we have all covered. That this is what you could see. Yes, judgmental about non-compliance. No eye contact, no introduction with name. Then he interrupted the consultation with phone call, disclosing details of another patient. Appears insensitive towards the patient. No eye contact, is unbothered about listening to the patient, seems to have a sense of being better. So I think you have covered almost all points. And see, I know, I'm sure you all must not be doing this, but we do come across doctors who are like this, would behave like this. Personally, also, you may have known some doctors who are very rude and very aggressive with the patient party. So therefore, even if one person behaves in this manner, all others are blamed for being insensitive and not really doing good. So 93% of the communication is non-verbal. 7% of the communication is through word, but I think we could all see the way he was behaving with the patient. He did not make eye contact. He did not smile. He didn't even, of course, maybe he knows the patient earlier, so he did not take an introduction. But calling the patient by name is another good way to start your, showing that, yes, I know you. Anything else that we have missed? He made mockery of patients' religious beliefs. Mridlani, is that what you wanted to say?
Yes, ma'am. And I also wanted to say that in terms of body language, he didn't seem to be leaning towards the patient or like sitting towards the patient. So
Yeah.
it seemed like he already disconnected with the patient initially itself by not turning towards the patient.
Yeah, absolutely. So that clearly shows that he was not really, not interested, you can say so. Am I right? Not interested. And then at the take it or leave it attitude. Absolutely. So this wave of practice was probably okay maybe some time ago, but today patients don't take it. They don't take it. They would just straight away tell you something and then go back. Now let's see the second video could he have behaved in this manner? Let me show you the second video and observe how he does.
Next. Hello, Mr. Kannan. How are you? Please take your seat. Thank you. What can I do for you?
Doctor, I think I have a problem with my leg.
What happened?
4-5 days back, I went to Sabrimala and I had to walk barefoot for some distance. I'm very scared now because my leg is swollen and painful in the last 4-5 days, and I think I did a stupid thing by walking barefoot.
Let's see what we can do. Good that you realize the importance of foot care. Meanwhile, how are your sugars?
Actually, my fasting sugars were 140, but it was some months ago. I was feeling all right and I didn't do the HbA1c. It is so expensive, you know.
It is expensive indeed, but it is so important to get the investigations prescribed by the doctors, because otherwise it's very difficult to give the treatment, you know, and treatment may not work as well. Anyway, can I examine your leg?
Yeah, sure. Sorry, sir, it was my mistake. I didn't do the test.
Hello? Yeah? Yeah. Excuse me for a moment. Yeah. What's the name of the patient? So he doesn't want the CT scan, right? Yeah. Try to explain to him the importance of CT scan. Yeah. When I come for rounds, I will also tell him. Okay. Thanks for informing. Thanks. Bye. Sorry about that. You got infection in your leg. So how are we doing regarding the quitting the smoking?
Regarding smoking, it's doing good. Actually, I brought it down to only 1 or 2 cigarettes per day now, doctor.
That's good. But total quitting is very important. See, if you have reduced from 1 pack to 1 or 2 cigarettes per day, quitting that is also not very difficult, you know. And how are we doing regarding the exercise?
Yeah, going on, but I must admit not so regular.
See, exercise and diet are as important as your medicines, if not more. But for the time being, you need admission for sugar control and control of this infection. Is it okay with you?
Whatever you say, doctor, you have to cure me this time, and hereafter I will definitely take care of myself. This will not happen again.
Yeah, we need to control your sugars and control the infection. Otherwise, it may go for gangrene and may lead to further complications. Now, the sister will go through the procedure and admission process. Okay. And meanwhile, you have this leaflet and you can go through it, which will help you to follow the regimes. Okay. Thank you very much.
Thank you so much, doctor. It was so kind of you.
You're welcome. Thank you.
So I can see a lot of comments in the chat box. Yes, I think overall the behavior of the doctor was really very cordial. Yes, involvement, good body language, comforting, friendly, good eye contact, helpful, courteous, encouraging, good communication skills. Yes, normally we don't take call unless it is urgent. And if we take call and if we just let the patient know that it's urgent and I need to take, even that's good enough. They are okay with that. They don't mind if we take a call, but the thing is that we need to, kind of value their time and just make a mention that I need to take this call and it is urgent. So if you saw the length of the video, the second video took lesser time than the first one. So when you talk to the point, when you communicate, in a professional manner, you would not talk unnecessary things. You will be to the point and very, very communicating, effectively communicating. So this was just to give you a feel of how the whole communication can be better. All of you seem to be very seasoned and experienced clinicians. So I'm sure you must already be practicing these things. Nothing for me to add on, but I'm sure you must be seeing doctors not practicing these skills in their patient handling. So rest of the time we are going to spend in understanding some of the essential skills. Although there are many skills that we need to learn. I'm sure you must have learned and you must be practicing. But I have identified 10 skills that I think each one of us need to have in with us, so that we can, not only deliver quality care, we can ensure patient safety, and also for us also it plays a kind of a safe game. So the first skill that I want to talk here about is building rapport. What exactly we mean by building rapport? Write in the chat box. What exactly we mean by building rapport? Okay, establishing connection. That's nice. Enabling communication. Very nice. Patient comes in discomfort to make him or her comfortable, to whom you can share information. Absolutely. Establishing a connection, that is getting to equal level. Wonderful. Nice perspective. Talk about other things apart from illness. Okay. Comfort in communication. Absolutely. So I think I would say the simplest, definition of building rapport would be creating comfort and familiarity with the patient, because you are entering into a therapeutic relationship with your patient, long-term relationship with your patient. So it's very important to create that comfort, and familiarity. Now, my question is it only for the patient or it is for us also? Both, absolutely. It's not just for the patient. A lot of time we think it is for the patient that we are building rapport, but that's not true. For us also, we have to feel comfortable, because a lot of time we may have to say something to the patient which may not be very comfortable and easy for the patient to get. So if we are able to create that comfort and familiarity, it becomes easy for us to explain them. Now, how much time do you think it takes to build rapport? How much time do you think it is? You can unmute and speak. I mean, keep the answer to the brief, but then if you want to speak, feel comfortable. Couple of minutes. Okay, 30 seconds.
Yeah, I think it should not take more than 15 to 20 seconds.
Very, very true. And if I tell you, building rapport does not take time. It's more a matter of, or a factor of our intention to build rapport than the factor of time. Because a lot of time when I take these programs for the government sector doctors, they say, we don't have time to build rapport. How do you expect us to build rapport? So I tell them, building rapport is not about time, it is about intention. Patient comes into my chamber, I'm doing something, I don't lift my head, I don't make eye contact, I don't show them where to sit, smile, completely forget, I don't greet, I don't return their greeting. They come and stand and they will ask, where should I sit? And then I say, mere sit pe baitho. Imagine that. On the other side, the patient comes in, I lift my head. If I'm doing something, I say, please back here, let me complete this. Or I smile, or I say, who is this with you? Your rapport building has already begun. So rapport building is not at all about time. It's about intention. Do I want to build rapport? And as very rightly said by you, it's a matter of just couple of seconds, not a very, it doesn't take much time. So let me, take you all through this building rapport. So I'm going to be sending, how many participants do we have? Can I have the camera on for all those who are there, so that I can know whom all I can put in the breakout room? Yeah. Okay. So we have breakout room, Mrilani, I hope. Yeah.
Yes, ma'am.
Okay. So I can see only, including Nani and me, I can see only 9 of us there. How about others? How about others? Because if you're not there, then how will I put you in the breakout room? Okay, thank you. So again, now we are 10 of us. So Mrinalini, me and you, we can be kept out. But if you could put, put them in pairs in the breakout room. By the time you create breakout rooms, are
Yes,
you
ma'am.
comfortable creating breakout rooms?
Yes, ma'am. Yes,
Okay. So create 4 breakout rooms so that you can put all of them in pairs. So by the time Mrinalini creates breakout room, you will get total 3 minutes time. In the first 1 minute, one person will speak and the other one will listen. And then the second minute is for the second one who was listening, who will do the talking now, and the first one will listen to that person. And the last 1 minute is in case if you are still left to, discuss something, so that your discussion is complete. So, whichever profession you are, the prompt for the discussion is, if I was not in this profession, where would have I been? Should I repeat the prompt? Okay. If I was not doing what I am doing, so if you're a doctor or a CA or a lawyer, if I was not doing this, what would have I been doing? So total 3 minutes. 1 minute, one will speak, second one person will listen. Second minute, the second person will speak, and the first one will listen. And 1 minute extra just to complete your conversation. So Mrinalini, can we make the breakout rooms?
Yes, ma'am. I'm just cross-checking
Yeah.
whoever has the video on so that I can.
Yeah. So you will get the message to join the breakout room. You have to join the breakout room, and you will be there in the breakout room. Yeah.
Yes, ma'am. The breakout rooms are ready. So whenever you are comfortable opening it up, I can open the breakout rooms.
Have you created?
Yes, ma'am. And do you want to set any timer for the breakout room that it auto closes?
Total time is 3 minutes. So you
Okay,
can
so should I auto close it after 3 minutes?
3 minutes. Absolutely.
Mhm.
So you can just have the timer on, and after
Alright.
1 minute, you just message in the to all the room
Okay.
that 1 minute is over, so that they can exchange their role.
Yeah, I'll send out broadcast messages.
Sure. Yeah, broadcast. Yeah. Thank you.
No problem. Okay. And Kamakshi, ma'am, I should add, do you want me to add you also to the breakout room? Sorry.
Unmute
you're
your device,
muted.
Kamakshi. Kindly unmute your device.
Only if you need me to equalize
Yeah.
numbers.
Yeah, I think that's
Go
fine, right? Okay. All right. Thank you. Okay, I'm opening the breakout rooms in 3, 2, 1. Yeah.
So Ketki is not part of any breakout room?
She is, ma'am. I think she was joining and perhaps her internet lagged because in
Oh,
room 5 it says she hasn't joined yet, but I think she must have some internet.
maybe she would join that. Yeah.
I've set a timer for 1 minute each so that we can send out
1 minute
broadcast.
is broadcast, that 1 minute is over,
Yeah.
so that they can exchange their role.
Sure. Yeah.
So is there anybody in the any of the breakout room where there's only one person?
It's only Dr. Ketki's room. So there's
Ketki is here, like, Dr. Ketki is here only, no, with us.
yeah, but under the breakout room thing, it still says that she hasn't joined.
No, but in any of the breakout room, do we have only one member? At least that person could be sent to the other.
No, sorry, no.
Everybody has a partner.
Yeah, everybody has a
Then
partner.
it's okay. Then it's
Yeah.
fine. So you have broadcasted that 1 minute is over.
Yes, ma'am. So only in room 5, I think Dr. Sonu is the only one who is there because I think Dr. Ketki's call got dropped.
So move her to the other
I'll
breakout.
move her to, okay. So I'm just moving her to room 3.
Uh-huh.
Mhm. Okay, now we're on the last minute.
Yeah. Messaged?
Yeah.
Yeah. Okay. I can see now there are 3 people in room number 3. Yeah. So 2 people are not assigned, Rajan Joshi and JP Saiful. So
Yeah.
maybe
No, JP sir is not a part of the participants. Yeah, and only Rajan sir is, so because he didn't have his video on and we didn't want me to send him, so I didn't. Ma'am, I'm just sending out the broadcast at 3 minutes.
Yeah.
And you can let me know when you want me to close all the rooms.
So once I think automatically it will get closed if they.
Oh yeah, I didn't put the timer, so I can close all the rooms now.
Yeah.
And they'll get 60 seconds to join back.
We'll wait for everyone to join before we start the discussion.
Mrinalini, I was all alone in the beginning in the breakout room.
Yeah, we're very sorry, ma'am.
And then you shifted me to the other one.
Yeah,
So I
so
didn't get to hear what the others said.
I'm so sorry. I think one of
It's
the
okay.
participants had like a network issue, so they couldn't like join the breakout room. I think everyone's back, ma'am. So the breakout
Okay.
rooms.
So would anybody like to share their experience? How did they feel? I just gave you 3 minutes to connect with each other.
It was wonderful connecting with Dr. Deepa Mungi. Inherently, she is a counselor and she likes to connect with people. So I think through the medical profession, she is able to communicate and be at the level. Even we've seen her when she made her opening statement, she was connecting with the parties in a manner which and explaining in a manner they would understand. I mean, many times we know a lot of information and then we tend to say thalamus and all that, and the patient is blank. So that's not the way one should communicate. So I think Deepa has that liking for counseling, and that's her major tool in therapeutics. This is what I learned from my discussion with her.
Wonderful. So imagine just 3 minutes of interaction and you could get so much in that 3 minutes. I'm so glad.
Right.
Yes, Deepa, go ahead.
What I understood is sir is very open-minded and is quite adventurous also. And makes everyone feel very easy. I mean, if there were what we could get from his opening statement was that he was the only person who actually inquired about what the patient feels. None of us were actually bothered about what the patient feels and whether they could find our mediation place or something. So he got me at ease within minutes of joining, and I was not able to start off well. And I could speak for I think 20 seconds. Then he said, I will continue with my statement. So he was very encouraging and he got me talking. I mean, that is a skill that I would appreciate, and that's the best part of him. Thank you so much.
Deepa told me not to praise her and she's giving it back to me.
Thank you both of you. Anybody else who would like to share your experience?
Should I?
Please go ahead. Yeah.
My meeting with Dr. Subodh,
Dr. Sudhir.
Sudhir Rai was very good. I came to know what he is, and if he would have not been in this field, what he would have been. And it was very smooth and cordial. And he was very open, very frank, very to the point.
Excellent. Excellent.
Anything he wants to communicate about Sudhir Rai? Yeah.
Yeah, my communication with Praveen was really very good. His seniority could be understood with the precise communication that he gave, that he's from a family of chartered accountant. His wife, his kids, all kids are chartered accountant. What he would have liked to do was to carry out his father's profession if it was not going to be this. But how satisfied he is today, and what he is doing at present for, and how he loves his business of doing insolvency along with his 12-13 colleagues. It was a great experience to know him.
So imagine in these 3 minutes, if you could communicate so well, if you all communicated with your patients, not you, when I say you, not just you, but generally, if we all communicated in the same manner with our patients and their family member, how impactful that communication would be. So I introduced you to the concept of building rapport. Building rapport is a proactive approach. It will happen only if you want to build it. And it's actually a concept of the first golden minute. Let me share the screen and show you the slide that I want to, bring to your. Give me 1 second.
It is not in any doctor profession. It is in all the profession. If you go to the architect, legal, chartered accountant, in each and every profession, this is very important. Your client or your person or your staff should they should trust you, love you, believe you, encourage you. All that is very important.
Sir, I completely agree with you. And in any sphere of life, if you start, proactively building rapport, actually it smoothens your work. It makes your jobs easy. So absolutely, there's no doubt about the fact the rapport building plays, a role in getting the work done. But in healthcare, why it is more important? Because when patients come, unless they have that trust in the doctor, they will not come out with the information that they need to share for the purpose of diagnostic accuracy. A lot of time we see patients hide things. They don't share everything because they hesitate or they fear or they feel that they will be judged or they will not be respected for whatever. Like for example, if somebody says I am HIV positive, or if somebody says I belong to LGBTQI community, so they fear that if they share this information with the treating doctor, the doctor may not look upon them or will not treat them well. So therefore, proactively building rapport will create that comfort where patient will be more upfront with the information, and that will help in diagnostic accuracy. So as I said, we'll be talking about some of the essential skills. So the first one that I want to introduce is the art of building rapport. I think this is one skill every healthcare professional should learn. And as very rightly said by you, it is not just for doctors or nurses, it is for everybody who should, make a proactive effort to build rapport. And it does not take time. It is actually not being friends with the patient. It is just being friendly with the patient so that the patient feels comfortable and respected. I think this is one skill that we not only we need to have, but we should make sure that every healthcare team worker working with you learns this and also practices it. The second skill that I want to talk about is prompt attention and attentive listening. So again, we'll do a small activity to understand the importance of listening. So Mrinalini, this time you will be actually again putting them in 2 breakout rooms. But before that, I want to put half of them in the waiting area. So those who will go to the waiting area, instruction for them is that please try to recollect any one incident that you really you were very happy, like something really great happened in your career and you were very happy about it. and you want to share with your partner. So half of the Mrilani participants will go to the waiting area, and they will take 30 seconds to 1 minute to just recollect what they want to share. So maybe you can write down your points in the notebook, what you would like to be sharing. So Mrilani, can you quickly put them in the waiting area? Again, we have, excluding you and me, we have 8 members. So
Yes,
maybe
ma'am.
put 4 of them, any 4. They can
Okay,
be put
any
in the-
4.
any 4 can be put in the waiting area, and they will be preparing to talk. Okay, Rajan Joshi has admitted. Okay.
I'm just
Oh,
putting.
I'm so sorry. I took. Have I brought?
Sorry. No, that's okay. I can put Sir back. No problem.
Yeah. 4 members will go
Yeah.
in the waiting area, and those who will go to the waiting area, they need to start preparing their thoughts for sharing.
Yeah. Yes, ma'am. So 4 of them are in the waiting area now.
Okay. So how many people we have? We have 5.
1, 2, 3. Ma'am, so Kamakshi ma'am is, yeah,
Kamakshi will stay here, just an observer. Okay. So but the rest 4 will be put into the breakout room. So
Yes, ma'am.
instruction for 4 of you, those are going to be put into the breakout room. When your partner does the talking, you will not listen. You will pretend that you are not interested. So how will you demonstrate that? How do you think you can show that I'm not interested in listening to what you're saying?
Close my ears.
Oh no.
Start playing with the phone, start Candy
So
Crush.
maybe somebody can, start talking on phone. Somebody can actually, not give any expressions, just look like this and don't give any expression. Somebody could actually switch off the video. And you can choose what would you be doing. So, you have to basically demonstrate that I'm not listening to you and I'm not interested in what you're saying. So Mrinali, quickly put them in the breakout room. And then once they are there, create 4 breakout rooms.
Yeah,
so
done.
Put 4 of them, and then rest 4, take them in, and then put them also in the breakout rooms.
Yes. So do you want me to initially open all the breakout rooms and then assign the 4 people in the waiting room?
Whatever suits you. If you want to take them all in, but
Yeah,
then
I think
it's difficult for you to remember whom to put in with whom. So it's better if you put all these 4 of them in the breakout room first, and then we will take them in and then put them also
okay.
in.
So I've noted down everyone. I don't know if you can open all the breakout rooms and then assign participants to the. Okay, yeah. Sorry, you can do
And
that.
I'm
I'll
giving
open
you
all the
time.
Yeah, I'll open all the breakout rooms. I'm so
And-
sorry. My bad. Yeah.
Sorry,
Yeah,
we are trying to use technology to our advantage. It might be little cumbersome, but then you'll enjoy.
Right, ma'am. So I'm admitting all the participants back in.
Okay.
Yeah.
Yeah. So we can take them all in. And
Yeah.
then,
They have all joined. So I'm just assigning.
so you're going to be put in the breakout room with your partner.
Yeah.
Yeah. So one by one, you will be going to your breakout room.
The
Mrinali,
same partner or other partner this
No,
time?
new partner. We'll give you a new partner.
Okay, fine. Thank you.
Yeah. Done.
So everybody has a partner. Can you ensure?
Yes, ma'am. But I am not sure if
Yeah.
Rajan Joshi sir can hear us.
Only Dr. Sudhir does not have a partner.
Yeah.
So can you send Dr. Sudhir was already here, no? So there's no point sending.
Right.
Thinking if you
So
could send Kamakshi, but then both of them know the tricks, so there's no point. So maybe Dr. Sudhir can be put into room
oh
number.
no, Rajan sir joined room 4.
Okay, great,
Yeah.
great.
Yeah.
Great, yeah. So Rajan sir knows the activity.
I think before he left for the waiting room, he was here as well, right? So
I don't know. Let's see what happens. Let's see what happens.
how much time should I give for this?
Maybe a minute or so, not very long.
Or just a minute?
Yeah, just a minute is enough. Yeah. So I hope it is going smoothly.
Yes, ma'am.
Kamakshi, you wish to say something?
Absolutely, absolutely. I'm absolutely loving it.
Thank you.
Kamakshi, I am with you. So am I.
Hi, JP. It's so good to hear your voice. I can't see you, but always a pleasure to just
I
know.
in fact told Dr. Indu that I'm here to listen to you. So I'm not going to be, making any guest appearance. So she said, I want to see you. I said, okay, when I reach home, I will. And I've been actually following. I'm sitting on my table and following.
Thank you for having your camera on. At least I could see you.
Indu, it's so much fun what you do. Look at people who are so experienced 25, 30 years in the medical profession behave like kids.
Absolutely.
And see, adults also want to learn, but unfortunately, we should know how to teach them.
Absolutely.
Because you can't do a lecture method because that won't never work. Good for children in school, yes.
With adults, it's all the more important because you have to break the ice and make them, comfortable to open up. Yeah, sure.
The trust building, that's what basically the whole, you talked about so beautifully. And this is what, the biggest part of communication is listening. Unfortunately, we don't. And doctors anywhere know all.
Yes.
They know everything. They don't even
Only
need.
that we are selective in showing those courtesies. We are not, we don't treat them as equal. So we normally, pick and choose and then we behave the way.
You see, I've seen that people who head it, like RML Hospital and other, head of departments, when they have legal issues and they land up in court, you should see how they behave in court.
I'm sure. I'm sure.
I was literally, beginning years in the law profession. I was about 1.5 years with my senior, and he was handling government work. And this person, he was commandant of CRPF, and he was, removed, and his writ was filed, and I would see him running after me. His files in his lap and telling, JP sir, mera matter aane wala, please chalo. Imagine I'm 1.5 years in the profession, and that's the Director General of the CRPF.
My goodness, yeah.
And so therefore, how circumstances can change, with how people communicate, then so different.
True. So Mridalini, have you taken everybody in?
Yes, ma'am. I was
I
was just waiting for
Dr. Subodh is there. Yeah, that's good.
I think everyone's gonna join back now.
To extend my apologies to Ketki because I pretended to be too rude before she actually thought that
I think
was
I should
so.
be apologizing to all of you.
Before she thought that was for real, I had to actually tell her the truth. I'm sorry about that.
I hope you did not tell her during the activity.
No, after she finished, I said I'm sorry.
No.
I couldn't see her sad.
Oh my goodness. Okay. So those who were sharing their story, what did you feel? What did you go through? Those who were sharing your story.
Yeah, can I say something?
Sure, please go ahead.
Yeah, because initially I thought it was a technical glitch and we could not connect and I can't hear or something like that. Then when he took a call or something, then actually because we are in this seminar, then I thought that this must be some thing which he was supposed to say. But then I felt like shutting up. I did not feel like sharing anymore.
Oh my goodness, I'm so sorry.
She stopped halfway. I was actually focusing on her talk, though I pretended to be on
But
the
you were
call.
not responding. You were not.
Yeah, and she was going to tell me a happy incident, but I realized there was nothing so happy about the incident actually she wanted to say. So probably she wrapped it up without actually telling me the details.
So sorry.
Right?
So sorry. Anybody else who would like to share their experience?
I couldn't pretend not to hear. Huh? I was with Praveen in the room, but I just couldn't. I had to hear him out. So you told us to act, but I just couldn't do it. He's too senior.
I understand. Yeah, I agree. I agree. And I respect that. Yes. Dr. Sudhir?
I was ghosted by Ranjan.
Ghosted.
Yeah, he didn't.
We did.
Oh.
So it was, I didn't have anything to do.
Okay, okay. But I think it gave you a taste of how you feel when you want to share something
Yes,
and there is nobody to
there's
listen
nobody to listen.
and nobody understands. You know, listening plays a therapeutic role. There are organizations where you call and you talk about your problem. They don't suggest you anything, they don't give you any solution, but they just listen and they'll be saying, yes, I understand, yes, it must be very difficult, yes, I get what you are saying, I'm sure it must be really hard for you, and that's all. That's all. But unfortunately we have lost the power of listening. Hum rule is 80% listening and 20% talking. I think we do the other way around, either 80 or 100% talking. We interrupt the patient. We don't allow the patient to speak. How much time do you think a patient will take on an average to narrate about their problem? Any guess?
I'm
15
not
minutes.
medical, but around 1.5 to 2 minutes max.
Okay. What do others say?
5 to 10
Of
minutes.
the minute.
Depends on the ailment they are suffering.
15 minutes.
On an average, patients take 60 to 80 seconds to narrate their problem.
Hmm.
70% of the patient. 15% of the patient would be such who would not open up. You'll have to literally ask them, tell me what is it. 15% of the patients would be such who would just not stop. Usually elderly patients, senior citizens, they will start from 10 years ago what exactly happened. And how do we stop them? If we are in a government setup, the answers that I receive from my residents, they say, we tell them, ज़्यादा कहानीबाजी मत करो, जो पूछ रहे हैं उसका जवाब दो. तुम्हारी फालतू बातें सुनने के लिए यहाँ नहीं बैठे हुए. Of course, I'm sure in corporate hospital you can't behave like this. So there, how do you stop the patient?
फुर्सत में बात करते हैं.
I usually
By asking a
tell them,
pertinent question.
I've heard about this,
Huh?
so thank you. I know, and you tell him exactly what he's repeating. So then they go to the next point or they stop.
So a good way could be, yes, I understand that you want to talk about your previous problem, but it will be nice if you tell me what for you are here today. And especially if I am being insulting to the patient, especially to the elderly patient, they will usually have their grandson or granddaughter, with them, who would be hearing you talk like this with your patient. ज़्यादा कहानीबाजी मत करो. बहुत सारे पेशेंट है, तुम्हारी सिर्फ कहानी सुनने के लिए नहीं बैठे हुए. They take that with a pinch of salt because probably they don't have anywhere to go. But if they get a chance, they would not mind setting their scores with us. And that's where aggressive reactions come from patient party. And it's not just with the doctor, they would experience something like this. They go to 10 places, then they enter the hospital parking person, then the front desk staff, then the person at the doctor's chamber, outside the doctor's chamber. Then after they move out of your room, they go to radiology, lab, pharmacy, and where not. And wherever they go, this is the same behavior they receive from the healthcare professionals. So that adds insult to the injury. And there comes a point when they just lose their control and they become aggressive. At least these cases can be prevented if we knew how to communicate with them. So I think this is one area we can focus on. When the patient does the talking, of course, patient will talk things that are not relevant. If I'm in a government hospital, मैं अगर प्यार से इतना बोल दूं, बाबा जी 10 साल पहले क्या हुआ था वो ना बताकर मुझे ये बताएं अभी आप मेरे पास किस लिए आए हैं. Patient will certainly become alert. Oh, I'm talking something not relevant. Even the attendant would say, दादाजी आप क्या पुरानी बात बता रहे हो, अब की बात बताओ ना क्या हुआ है. उनको क्या अभी बताओ, क्योंकि they will feel, oh, my grandpa is not acting right. But then we have to create that kind of a place where they don't feel disrespected. So the second skill that I want to, recommend to all healthcare professionals is listening. There cannot be a worse feeling than bearing an untold story inside you. I deliberately asked you to recollect any incident that was really, real fun. You really wanted to share. And then I didn't let you share that. You didn't have the audience. I'm sure those of you who could not do it, you felt extremely, extremely bad. That's the plight of patients when they come up to us. See, for example, if somebody has a nodule here or a nodule there, they would be, what do you think will be their thought process? It is cancer. And if they feel it is cancer, they want to talk it out. They want to check with you. They want to know from you, is it cancer? And if at that moment, according to you, if that nodule is benign and it has nothing to do, you can well imagine your reaction and you can well imagine their anxiety. And as a result, they feel that we have not been attended well. So it is not only important to listen to them attentively, but also we have to demonstrate that I am listening. Especially now we have a third person in the room. Since the time we have started having, information going to the computers directly on the iPad or on the, laptop, or there's already another person in the room, and that's taking away our attention. All the more important that we have to make sure that we interact with the patient, we make eye contact, we smile if it is appropriate, we stop doing things when patient is saying something very important or serious, and we show our interest by leaning forward. That shows that I am listening to you and I'm trying to understand what you are saying. When you nod, you communicate that yes, I'm with you, I'm understanding, I'm agreeing with you. And then if you don't interrupt and if you allow them to speak for that 1 minute, when they're able to talk about their problem, and in case if you need to ask something, you make a note of it and then you ask a question about it, their satisfaction level is going to multiply 100 times. But the problem is most of us like to just ask and ask. So the third skill is questioning skill. 80% of the diagnosis can be made if we know how to ask open-ended questions, allow the patient to speak, and listen to them attentively. Your patient is telling you the diagnosis if you listen to them. But incidentally, our questioning style is very different. So what is open-ended questioning? What do we mean by open-ended questioning?
A question which has an answer other than yes and no.
Absolutely. So a lot of time, if patient comes with fever, what are the common questions we ask?
When did it begin? Is it associated with any other symptoms? Have you lost weight? Did anybody around you have fever? Any skin rash that you have? Are you able to swallow? Do you have pain in the throat? Some of the are there mosquitoes in the?
Excellent. And all these questions, what category are they?
Preliminary.
They are
preliminary.
Okay, good guess.
Open-ended.
There's a closed-ended.
These are closed-ended questions. Sir, you gave a wonderful example. I mean, you almost talked about everything. So we all have a tendency to ask closed-ended question. We think if we ask closed-ended question, we will get, a quick information. But an open-ended information will give you volume of information, which will be far more than that you can ask. And when you ask questions like this, one, it is very exhausting for you because you will have to actually remember that I have to ask about it, I don't have to miss it. So it becomes very, very challenging to remember everything. Suppose if you forgot to ask something, And then the patient turns out to be suffering with that particular condition. Gone case. So questioning skills, which are usually not taught formally in medical college, which I wish are taught, actually it is to remember that when you ask the first question, it has to be, tell me, how can I help you? Tell me what brings you to me. And if you ask that question, patient will tell you all the story. For example, if you saw the first video, he said, what? You remember the first video? What? So in a way, what is it? Why are you here? So when you ask like this, definitely the patient will say, sir, I have stomach upset or this and that. And if you say, Hanji bataiye, kis liye aaye hain? Patient will start from this, sir, 2 days ago, I went to a marriage party. I think I ate something that I'm not able to, digest. That has really stomach ache. And then I had nauseated feeling yesterday, and then I had slight fever also. And I took some medicine. I tried taking, all antacid and all those things. I even took crocin for fever, but it's not working. I'm not out of it. So patient has given you almost all details that you require. When you have to ask an open-ended question to your patient, how will you ask about fever? What one question could have got you all the information, sir? If not all, most of the information. Dr. Subodh, what one question could have got you most of the information? Patient with fever. आपने मुझे बताया कि आपको बुखार है. I hope everybody understands Hindi. Okay, thank you. In case you don't understand, please ask me to repeat. I will speak in English once again. But when I speak in that language, it brings that flavor, Okay, आपने मुझे बताया कि मुझे बुखार है. मुझे बुखार के बारे में विस्तार से बताइए. Just one question, and then you have to listen. You'll get lot of information. One, you will not exhaust yourself. Second, you are not bombarding your patient with खांसी है, जुकाम है, चिल्सन राइगर है, कितना गया मैक्सिमम, कौन सी गोली खाई, कितनी बारी खाई, कोई दवाई और ली थी, किसी और को भी है, मच्छर है क्या? 10 questions you will have to ask. But if you ask just one question, tell me about your fever, you'll get more information. This will also include things like their feelings, attitude, their understanding. And we have to always start with the open-ended question. Of course, that can be followed by probing questions when you want to get more details about one particular thing that you think you want to focus more on. And then, of course, you can finally ask closed-ended question, which will be more like a checklist to make sure that you have not missed on anything. I think this is one skill we all have to learn when it comes to questioning. So questioning skills are very important, and we must train our doctors and our healthcare professionals to ask questions in an open-ended. As I said earlier also, 60 to 80% of the diagnosis can be made if you ask open-ended question, allow your patient to speak, listen to them, and it will actually leave a place for both doctor and patient long-term, get into a long-term relationship. But that's only if I have the patience to listen to my patient. Then the fourth skill that I want to talk about is skills to build trust. I think that's one important skill that we really need to work, which we never had to work earlier. But now I think proactively we have to earn our patients, patients' trust, because treating the patient with respect and equal human being, and then listening to them, then accepting the legitimacy of their views. So when you ask them, what do you think this is? And a lot of time when you see their answer is not making sense, so instead of making mockery, if you say, you are right in your place, but that's not true, and then you explain them further, it doesn't give them a feeling that you're a fool and you don't know anything about. But it gives them an idea that, okay, my doctor knows more, so he can explain me better about what it is. So you can, demonstrate your knowledge and clinical skill by discussing the disease and also disease management plan with your patient. So when you do this, your patients not only have trust in you, but they will come back to you. So I remember I had sent a relative of mine to a friend of mine who's a gynecologist. So this lady had to undergo hysterosalpingiography. So they had gone as a couple to 2-3 hospitals, but they were not very satisfied. So she called me saying that, do you have any friend who is good? So if you could refer us to her. So I sent them to a friend of mine. This couple, they asked n number of questions, a lot of questions, because they had a lot of doubt about the procedure. So they asked a lot of questions to the doctor, and in the end they said, I'm sorry. The husband said this, I'm really sorry, I am asking you a lot of questions. You must be really upset with me. And the reply that Kainek gave was, it's perfectly all right. It's my duty to answer your questions. You are paying me for this. And the very next day, the lady got her procedure done by her. So that's the beauty of getting into discussion and explaining, because patients also look for somebody who is confident, who is knowledgeable, and who is experienced. But if we say I'm knowledgeable, I've also seen doctors answering like this, कि इलाज करवाने आए हो या मेरी knowledge check करने आए हो. If patients ask a lot of questions. So when I talk like this, definitely my patient is not going to be happy. So whatever we do, if we are transparent, we are open to discussion, and we are practicing evidence-based guidelines, automatically your patients will have trust in you. You will also see that these patients, when they ask for a second opinion, and if we are not open to the idea, again that shakes their trust in us. A lot of time, rather than they asking that, can you speak to any one of my friend or relative who is a doctor, which we normally refuse. If we say I'm open to talking to your family doctor or somebody whom you want me to speak to, automatically they will have more trust in you, believing that you are thorough with your work and you're open to discussion. So there are so many ways actually to build trust. I think one of them is staying non-judgmental, especially when patients talk about their some lifestyle or something that we don't normally approve of, or we kind of think that's not good. It comes out in our expressions. For example, if the patient says I'm HIV positive, or if the patient says that I am into drugs or alcohol, or I'm from LGBTQAI community. So we have a tendency to kind of immediately judge the person. We don't know what challenges that person may be facing. So very mindfully we have to learn to stay non-judgmental, and also see how we can support the patient rather than judging the patient and being disrespectful. So another way of winning your patient's trust is treating the patient with respect and dignity. We are normally very nice with patients who are educated, look well-to-do, and well-behaved. But the problem comes if the patient comes from a poor socioeconomic status, or they are not educated, or they don't really know the social etiquettes that they are supposed to be practicing. That is where our behavior with them at times can change. So it's very important to remember that patients are patients, and we have to treat them with respect and dignity. A lot of time they may not even agree with what you're saying. They may not agree for treatment. They may not agree for surgery. But in spite of that, if we respect their autonomy and their right to decide, that's where not only you will be able to earn their confidence, but also will be, you will be calm because you did not get upset with them. So that's another skill we really need to have within us. And then comes the positive and helpful attitude. I think it's very important to remember when we are working with patients, if we treat them with negative attitude or a element of doubt, I'm sure when a patient comes to you with that thought process where they are doubting you or they are hiding things from you, I'm sure you don't like those patients. Same way, if we treat the patient with a negative attitude, they can read it that we are not being, neutral or positive with them. I personally feel, I think positive and helpful attitude is not only beneficial for patient, it is for us. See, if we are not looking at our work or profession or society or patient with a positive mindset, we are releasing a different set of hormones in our body. When we enjoy doing what we do, when we like doing what we do, when we are happy doing what we do, we release a different set of hormones. And when we are unhappy, sad, frustrated, we release a different set of hormones. So it's not just for the patient, for our own mental and emotional health, it's very important to check our attitude. So I can narrate a story, interesting story. Maybe you will be able to relate with it, and maybe you will see such people in your life. So there was a building being made, and there were laborers who were doing the construction work. So somebody who was passing that place, some visitor who was passing that place, stopped by and asked one of the laborer, "What are you doing?" So that laborer, in a very simple way, he said, "I'm earning my livelihood." So a lot of us work for money, which is perfectly all right. There's nothing wrong in making money. But if we are working just for making money, then I think it's a problem. He went to the second laborer and he asked him, "What are you doing?" He was a little frustrated, unhappy. In an angry way, he said, "Can't you see? Are you blind? Can't you see I'm breaking stones?" You will see people around you will always be unhappy and dissatisfied with whatever the situation is. They're not able to see the brighter side, but they always find fault with whatever is happening around them. He went to the third laborer, and he asked him, "What are you doing?" So he took him to the side of the construction site, and there was a huge map. He showed that map and he said, "There's a beautiful temple coming up here, and I'm constructing that temple." Three workers doing the same task, but with different attitude. So all of us are doing our job. Check what's your attitude. And if I'm working with a negative attitude, outcome cannot be positive. It can never be positive. So I have to, literally introspect and see, am I working with the positive attitude? And that's one skill I think we all should keep with us. Next is assertive communication. So actually there's a questionnaire I wanted to give you. But before I go further, I want to ask you what exactly we mean by assertive communication. Do we know what is assertion? Can somebody explain to me what is assertion?
Being in full control of what you are communicating to the patient, be it the ailment or whatever. Like, because some patients will come and say, "Ki the Google says this," or "the previous doctor said this," or "I've heard one of my relatives being treated in this manner, but you are saying something very contrary to that." So we should not be swaying to whatever they are trying to tell you, but whatever is your take on that ailment or how you manage is what you have to stick to. So even
When you
things.
use the word control, what exactly do you mean in this context? Being in the control. You started with this being in the control.
Yeah, control meaning if a patient has come for a particular ailment and the patient tries to take you in different directions based on what information he has or he has been told uh, by doctors or non-medicos, and tries to tell you, "Why don't we try this?" Like they may have heard of some medicines, or they may say that say people come to me for acne, so, or pigmentation or scars, and then they'll say, "Why not do subcision?" So they'll come with these words and pretend to be very knowledgeable. So I would say I'll be in control that do you think that should be the first line of treatment? Because it involves a procedure, and each procedure has its own side effects. Are you aware of the side effects? Or are you seeing only the good parts of it? And
So what is the feeling when you're answering like this?
I tend to be very, I try to pass on as much as information possible, because
What
as
is
a,
the feeling?
huh?
Mike, I repeat my
It's
question.
actually good. I feel
You said they pretend to be knowledgeable. So what is the feeling when we use this word?
when they pretend to be knowledgeable, that's what,
Knowledgeable.
yeah.
Yeah.
I'm okay, because I'm still in control, because I know that information is misleading, and I feel
Okay,
nice.
thank you. I think I want to give chance to somebody else to explain. What is assertion? Forget about patient care. In general, what is assertion? If somebody can just
See,
briefly tell me.
To
Briefly.
state with assurance, basically.
To
say something with assurance.
Okay, that's your understanding. Okay, great. Thank you. Yes, Mr. Rajan, I think you wish to add something.
According to me, when a person is assertive, means he has taken a position. He doesn't. He's not in a. He's not that flexible in communicating or otherwise receiving the communication from the other side. A
So
sort
that
of
is
a
assertion? Sir, is that assertion?
yes.
That's the thank you so much, everybody who has given their idea about assertion. That's the reason why we don't assert, because we don't know what exactly assertion is.
To me now it's
Assertion.
just, yeah.
Yeah, Preeti, go ahead.
Sorry,
Go.
sorry. It's
No,
just
no.
making a point. That's it.
Please go ahead. Yeah.
Yeah. I said for me, assertion is just making a point. So you get your point across. You're basically asserting your a view or an emotion, anything. You're just making a point across.
Assertion has 5 elements. Please remember. It is open, honest, positive, confident, respectful. Incidentally, we think assertion is being firm, putting our foot down, and
Madam,
sticking
please
to our
repeat
step.
now. Please
I
repeat.
will repeat, sir. I will repeat. Open, honest, positive, confident, respectful. And if we had all these five elements in any communication, we could handle any situation. I will not be spending much time on it, because one, because we are short of time. Second, because this is going to be covered in one of the sessions that I am going to meet with all of you on de-escalating aggressive patient party. And let me tell you, if we learned assertion, most of the conflicting situations can be handled amicably in one-on-one situation itself. I will be sending a questionnaire to one of the team members. They will share with you. I will ask you to take that questionnaire. There are 20 questions in that. After every 5 questions, you have to total the score that you have given to yourself on those 5 questions and write in the box in the form. At the same time, please note down that score in your notebook. So finally, you will have 4 scores for you. That means after every 5 questions, you will be having one total score, that is number 1. Then after the next 5 questions, again, you will have second set of answers, and then you will write the score in the form and also write the same number with you. I will explain you in detail what assertion is. You could handle most of these situations if you learned assertion. And that will also give you an idea about your communication skills. Is that okay? So I will not spend much time on it, because otherwise we will not be able to cover rest of the thing. But definitely we will spend a time on understanding what our communication skills are, and then how can we communicate effectively. So even most difficult situations can be handled if we learned how to assert. Okay. So this is assertive communication. Next is empathy. What is empathy? What is empathy?
trying to understand what the other person feels without telling them that you creating that victim-like feeling for them.
Okay. So we all experience 4 kind of, emotions in healthcare. Not only in healthcare, in a lot of situations. But I'll give you an example. Now there's a patient who has come to the hospital emergency. I'm on duty. I'm busy doing something. I'm just wanting to finish it because my duty is going to be off. Then another one will be coming in. So I just want to finish my work. And I'm hoping that somebody will come in place of me and will attend to this patient. And I take almost like 10-15 minutes and I make that patient wait. I can see
Make
that
that patient.
Sorry?
Wait. You make that patient wait.
I make that patient wait. I don't attend to that patient because I'm going to be off and I'm hoping that somebody else will come and take charge of the patient and will work on the patient. I don't care even if the patient is in pain. So that is apathy. As I said, there are 4 kind of emotions we all experience. That is apathy. And I'm not able to sense the sensitivity of the situation and the pain that the patient is going through. And I'm just insensitive to that pain and suffering. That is apathy. Now, the attendant of the patient comes up to me and starts arguing with me and says, what is this? We are here for the last 15 minutes. You're not ready to see. There's nobody who is, attended to us. What is the point of coming to the hospital? Why don't you close your emergency if you don't have, people to attend to the emergency? I'm very annoyed with the way he talked to me. In the heart of my heart says, I will make you wait for another 15 minutes. Happen? It happens? Sometimes it happens. That is antipathy. Antipathy. A lady comes with the child is unwell, feverish, mother is crying. Seeing her cry, I start crying. That is sympathy. Empathy is when I am able to put myself in their position and look at the situation from their point of view. And if I am able to feel in tune with their situation, that's empathy. And if we practice empathy, we could actually see the patient's world. Rather than judging them for being ignorant, for being rude, for being non-understanding, for having unrealistic expectations, we would understand their feeling. Denial is the first reaction to any shock. That's how the cognitive process works. They just refuse to believe. Unrealistic expectation is the way people want to pray and bargain. I don't know how many of you have heard the word dabda. That is reaction to any grief or loss. Denial, anger, bargaining, depression, acceptance. That's called dabda. That's how human mind finally accepts the defeat, death, loss, grief. All of us have the same reaction. Try to recollect if you have lost any family member or have anybody gone into serious condition. In spite of being doctors, you all must have gone through the same phase because that's how the human mind slowly accepts the reality. But when they deny, when they are angry, when they are bargaining, when they are saying kitna bhi paisa lag jaye mere patient ko bacha lijiye, we feel bad. But if we understand from where is this coming, and if I say, I wish money could decide the life, but that's really not possible. I remember in one of the government hospitals, I know some of you are literally sleepy, but I'm sorry I'm holding you back. for just 5-10 minutes more, but I want to send you back with clarity on taking the responsibility. How can we make things better? In a government hospital, a young boy was brought in by his parents. He was playing with kite. This is a real life case what I'm sharing. So he was playing with kite, and unfortunately he touched a cooler that had a live wire. He got electrocuted and he died. He was brought to the hospital. The doctors on duty, they tried to resuscitate. The protocol is that we always try CPR and then we announce broad dead. So they tried their best and they knew that they will not be able to save. They told the parents that the child is no more. It was a 15, 16 years old boy. No, illness, nothing. He was just playing and then he unfortunately touched the live wire. The family goes out. Somebody outside says, go and tell the doctors to try once again. Maybe sometimes, patients would come back. So they came in and they requested the doctor, Doctor साहब एक बारी और कोशिश करके देखिए शायद मेरा बच्चा बच जाए. Now, this is nothing but denial. Now, if I understand these emotional responses to death, loss, grief, I would talk to them and explain them. More than you, I would want to save your child. But honestly, the child is no more. We would be just, harming the body than doing any good. You know what was the response? The response was, Doctor, मैं हूं या आप हो? तुम खुद कर लो. तुम्हें मेरे पे विश्वास नहीं है? And then what happened after that? I think you would be knowing. So we cannot afford to communicate unprofessionally. We have to be very, very careful, especially in such intense situations where the family has lost or is going to lose a family member. They are emotionally not in that place. And we really need to understand and handle it and communicate with greater understanding. So that's one thing I always say, we need to have empathy in place. And of course, cultural competence. We know our country is, full of cultures. People come from all walks of life, from different socio-cultural background. It's time that we learned how to handle those things. And especially in the time to come, India is going to have a lot of medical tourism. I'm sure you all must be already handling it. You will have patients coming from across the world. So we better, equip ourselves with that competence to deal patients with cultural differences and be respectful and treat with them with respect and dignity. The eighth skill that I want to talk about is documentation skill. So this is a sample of a, doctor's note, in a gynec department, my resident. I don't know how many of you can really make sense of it. Another sample, again from a government hospital. I think in most of the corporate hospitals now we have mostly printed or typewritten case notes. But in government setup, we are still, continuing with handwritten. So what error do you notice in this?
It's illegible.
It's illegible. Nirali, you want to say something?
Yeah, sorry. I think illegible is one thing, but it's also that the particulars are given in Hindi and the explanations are all in English. So I think in terms of comprehension when it comes to government hospitals and everything, it's also about the language or the place that they're from.
I think more than anything else, I mean, whatever all of you are saying is perfectly all right, but more than anything else, you can see the patient's basic details are also missing in the document. Documentation has become so very important and relevant in today's time because that's the only safety measure that will prove that you have done something for the patient. Not written, not documented is equal to not done. There was a time when we said we did it, I forgot to write, people believed us. Today, if you don't document, it is as good as not done. So that's somebody is actually annotating on the screen. Can I request you to not do that, because probably sometimes you don't realize. सर शायद प्रवीण सर आपका उसके ऊपर स्क्रीन पे हाथ चल रहा है. That's okay. That's all right. But I'm just reminding that that's all right. Yeah. So you will see a lot of time, like you said, illegible handwriting, abbreviations, overwriting, done but not documented, documented but not done. Now there's this patient, this patient, she was received in the hospital emergency, full term in labor pain. The resident who saw the patient, she wrote magnesium sulfate, and then she said, transfer the patient to the labor room. The staff or the doctor on duty gave magnesium sulfate. The patient was moved to the labor room, but nobody signed that magnesium sulfate has been given. When the patient was received in the labor room, they thought that we have to give magnesium sulfate. They gave magnesium sulfate. Patient received double dose of magnesium sulfate. And you all know that would lead to respiratory distress. The lady had to be moved immediately to hospital ICU. With lot of struggle, they could save the mother, but they lost the child. A lot of time you will see that it is done but not documented. You would also see documented but not done. Nurse goes to the patient's bed to give medicine or injection. Patient is not there, maybe has gone for some referral or for, to the washroom. She comes back thinking that, okay, I will go again and do it. And she signs in her, nurse's notes or the medicine register that given. But then she forgets to give it. Now there's an injection lying here, but the chart says everybody has received it. Nobody knows whose medicine it is. You can well imagine the complication that can happen. So these are all common errors you will come across when you will handle patient. And then document not signed, dated and time. I think this is something we see very often. I was asking these doctors that why don't you sign it? They say we don't want to be identified. You can be identified within no time if somebody decides to find out whose signatures it is or who has written this document. Then language as a barrier, I think that's another problem which we see. A lot of people have difficulty writing, so they have poor writing skills. The problem is we have not learned writing patient's case sheet or referral or discharge slip in a formal way, in a meticulous way. Most of us are doing it by learning by doing. If you had a senior who was a good writer, maybe you will learn something like this. But if you don't have anybody who's really, learned, you would create documents like this. I don't know how much of sense is this document really making. So when you're creating a document, I think these guidelines can help us create a good clinical document. Keep the potential user in mind. If the document is for the patient, for example, if it is an OPD slip, the patient is going home, you're writing medicine. Please remember, patient will not be able to read your abbreviations. Even standardized abbreviations like OD, BD, TDS, they will not be able to understand. If it is the patient and patient family member, they will only understand layman's language. Of course, either it should be legible handwriting or it should be typewritten. Avoid all kind of abbreviations. I've seen a lot of time when you write medicine and you write SOS, I've seen patients taking that medicine without realizing that this was to be taken only if required. A lot of time we overwrite and we don't, sign it. There's a confusion whether the previous version is to be believed or what I can read or guess that is to be believed. So document should never be overwritten. And if you want to write something, please strike with single line and then rewrite, and don't forget to sign it that you have made the correction. The document should be complete, accurate, precise, and timely. There are so many protocols available on Google search. You will see that will give you the format of writing patient's case sheet, or writing discharge slip, or writing a reference slip. I think it's time we all learn these skills, because that's very important. And then, of course, the language has to be objective, clear, and concise. So therefore, we have to learn how to write a document. So that was about documentation. Last two skills, and just 5 more minutes and I finish it. It is time that we learned negotiation skills, because that's one strategy we need to help our patients discuss with us. One, we need to have patience. Second, we need to have communication skills. Then we need to learn how to explain them in simple and easy and layman's language. And then if the need be, we draw and explain them what is the process or intervention or the disease progression. All that requires talking, conversing with the patient. So if you want your patients to change their lifestyle, if you want your patient to come for follow-up, if you want to prepare them for a particular treatment or a procedure, all that requires discussion, talking, negotiation. So when we negotiate, we facilitate decision making without imposing our opinion and without compromising the clinical goals. I think it's time we learned it, because patient-centric care, shared decision-making, informed decision-making require negotiation skills. We cannot work without negotiation skills. And the last but not the least is collaborative skill. No healthcare functioning is in isolation. And when we work in our silos, we do a lot of error. So we have to come down to the level of collaborative practice where several experts will be working together on a patient. So we have to learn to actually collaborate in a manner that we reduce the error and we provide quality care to our patient. Working together, respecting each other's decision, jointly taking decisions, respecting overlapping of roles. These are the ways where we not only benefit the patient because they would get attention of multiple specialists, but also there is more clarity and transparency between us when it comes to patient handling. And if we learned collaboration and we learned these skills, it would definitely not only promote patient-centric care, it will reduce medical errors, it will also reduce the cost of treatment, it will improve our efficiency, and we all will feel empowered. It will also reduce the communication gap. That's in a nutshell about some of these skills that I could talk in this time. There's a lot more, but I know I can see many of you are very, very tired and sleepy. Sorry for holding you back. It's almost 15 minutes more than the time that was allotted to me. Any questions, any comments, any feedback?
In fact, I am an advocate, and having 35 years practice behind me and 10 years more experience as a company secretary, so almost 45 years experience behind me. And after having an interaction with your session, I think I wish I could have such a session when I started my career. Lot many things I learned, because it is not only the doctors, but I think most of the professionals, including my brothers in my profession, they need to learn all these skills, because in fact, lack of proper communication is one of the bedrock of all conflicts.
Absolutely. No doubt. Thank you so much, sir. I think your words really put back my faith in my work that I'm doing relentlessly.
No, it was excellent.
Thank you so much, sir. Thank you. Thank you.
Yeah. Which is the book you mentioned at the beginning of your...
So I have written this book, Fundamentals of Clinical Communication. I think I'll put it like this. Is it visible or it is other way around?
No, it's visible.
So this book is available on Amazon. It's very reasonably priced. I think just 300 rupees. But this book, anybody and everybody who is into patient care, if they'll read it, I've kept it very simple, to the point, and written in Indian context. I have not tried to copy paste what is being practiced in the Western world, because that will not fit in our healthcare delivery system. Our healthcare delivery system is very typical to our country.
Yeah.
Try to write it. Of course, it is for medical students, but then some of the chapters you will really find very useful, especially handling difficult situations. Sir, you are saying something. Please unmute your device, sir. Praveen, sir, I'm not able to hear you. Please unmute your device. I'm sorry, I'm not able to hear you, sir. Your device is
I'm
on.
not saying, I was just repeating what was said by you.
Okay.
So
Okay, sorry. So, but some of the, handling difficult patients, handling difficult situations, then interacting with the different population. For example, geriatric patients or pediatric patients. So again, very simple example, simple situation, but what should be the skills we should have? I've talked about them.
Okay.
If you get a chance to, read this book, it will be really nice. Yeah.
Very nice session, ma'am. Thank you so much.
Yeah, really. Got to
Excellent.
learn a lot.
Thank you so much. Thank you. I'm glad that you found it useful. The whole idea is, see, I always take responsibility on working on myself and working on my fellow professionals. I don't believe in blaming anybody. Of course, we can blame, but can that solve the problem? And that's why I think I volunteered when Ganda, got in touch with me for this program. I said, I'm more than happy to speak to, my fellow professionals, because I know that's the need of our. First, we need to take responsibility. And we are responsible for the tarnished image that we have for our profession. If we work together, we can definitely correct and make it more balanced.
Thank you so much, ma'am.
Thank you. Thank you. Thank you. So can we close this session?